delle opportunità e di rendere in qualche maniera i risultati conseguiti e quindi di amplificazione in qualche maniera anche agli altri della propria esperienza, per indurre sempre un maggior transito a livello europeo, una maggiore circolazione di specializzanti in sanità pubblica in base a quelle che sono le opportunità. Io sarò qui per quanto è possibile, seguirò questo evento perché mi sembra molto importante, spero che sia il primo di tanti altri che poi ne potranno venire magari con un aggiornamento su base annuale, sulla base dei nuovi ragazzi che vanno in giro. Vi auguro buon lavoro a tutti e ci andiamo sentendo durante il corso della giornata. Adesso passo la parola alla professoressa Mammina, che è il direttore della scuola di specializzazione di Igiene di Palermo. Grazie.
Buongiorno a tutti, vi sottraggo soltanto pochi minuti, intanto per darvi un benvenuto a Palermo per quelli che sono arrivati qui e anche diciamo virtuale a quelli che ci seguono da più lontano. La formazione a livello europeo è sicuramente un'opportunità per tutti gli specializzandi di tutte le branche, ma io penso sia quasi una necessità in fondo per gli specializzandi di sanità pubblica, perché la sanità pubblica ha sicuramente un beneficio enorme dal valutare gli eventi, sia dal punto di vista epidemiologico, ma anche dal punto di vista delle strategie di prevenzione e di controllo, con una diciamo, lente che non sia soltanto quella locale. In fondo tutti noi siamo un po' abituati a guardare ProMed o i CDC per cercare di capire che succede nel mondo al di fuori della nostra realtà locale, però penso che per capire qualcosa di più di quello che sta succedendo e per superare il livello di analisi dei mezzi di comunicazione, soprattutto riguardo a certi argomenti come quello appunto per parlare di uno che ci interessa molto da vicino, appunto quello dell'immigrazione, diciamo se riusciamo a superare il livello di analisi locale un po' diciamo forzata dai mezzi di comunicazione o dall'impellenza del momento, forse riusciamo a ragionare un po' di più e a valutare gli eventi in una maniera un poco più razionale, basandoci sui fatti e non sulle impressioni, e anche le strategie di controllo e di prevenzione guardate con l'occhio europeo o anche internazionale sicuramente hanno un maggiore significato, una maggiore validità e sicuramente una maggiore efficacia. Quindi penso che al di là dell'acquisizione di competenze professionali, anche competenze linguistiche, per uno specializzante di sanità pubblica, per un futuro operatore della sanità pubblica, riuscire ad avere contatti anche personali, perché poi in fondo anche così tessere la relazione personale è una cosa importantissima, sappiamo bene, è una marcia in più in fondo. Dopodiché vi auguro buona giornata e buon lavoro.
Buongiorno a tutti, sono Guido Maringhini, uno specializzando della scuola di igiene e medicina preventiva di Palermo. Spetta a me insomma, il ruolo di aprire questo convegno. Ci tenevo innanzitutto a fare dei ringraziamenti dovuti sia al nostro presidente di facoltà, il professore Vitale, che tra l'altro insomma, è anche stato il direttore della scuola di specializzazione di Igiene, sia alla professoressa Mammina, che hanno reso possibile questo tipo di convegno. Come ricordava il professore Vitale, effettivamente se siamo qui è anche perché domani ospiteremo una riunione del network europeo degli specializzandi in salute pubblica e avremo adesso modo di riuscire a capire un po' meglio di cosa si occupa tramite la presentazione del presidente del network, Rocío, che adesso verrà qui insomma, a spiegarci un po' meglio di che si tratta. Welcome to everyone. Since it's also an international meeting, I'm going to say hi to the international people we have here. And since Rocío comes from Spain, she's going to have a representation in English. se ci dovessero essere problemi non esitate in qualche modo a fare delle domande che poi in qualche modo avremo la possibilità di fare delle traduzioni in simultanea. Però prima di lasciare la parola a Rocío, io volevo fare notare il fatto che siamo anche in collegamento con Parma scusate, spostando il cursore scopriamo che è così. Prima
Ciao a tutti, ci sentite? Ci sentite? Oh. C'è qualche problema, mi sembra. Sentiamo. Cos'è stanno?
insomma, di come si
eventualmente tenere in considerazione eventuali il progetto a cui ho risposto io, quindi che mi interessava di più, era proposto dalla professoressa Maria Joao Corax della Scuola Nazionale di Sanità Pubblica Carlo III. Il tema era quello della qualità della vita e della salute degli adulti e degli anziani. I requisiti erano un tempo minimo di 4-6 mesi, una buona conoscenza dell'inglese e o dello spagnolo, la conoscenza di software statistici come Stato e SPSS e sempre specificato l'utilizzo di fondi propri. Gli obiettivi erano quelli di scrivere almeno un articolo scientifico, di pubblicarlo su una rivista scientifica e eventualmente anche presentarlo in dei congressi. Altre opportunità che mi erano state offerte erano quelle di frequentare come osservatore il Master di Salute Pubblica, che era presente sia in forma nazionale che internazionale, e inoltre potevo, pagando la quota di un corso, anche molto preparata, era portoghese, quindi parlava portoghese, inglese, spagnolo e italiano. Era sempre disponibile sia per spiegazioni sia per quanto riguarda ferie o necessità varie. Ha adattato il suo progetto a quelle che erano le mie capacità e mi dava libertà di frequentare master, dei corsi, seminari, anzi era lei stessa a suggerirmi quelli più interessanti. Cosa comunque che mi ha colpito è che alla fine dello stage, oltre a dare una valutazione su di me, che è stata inviata anche al direttore della scuola, mi ha chiesto cosa mi era piaciuto, cosa non mi era piaciuto e dove lei stessa poteva migliorarsi. In istituto avevo una impostazione computer, un badge, avevo libero accesso alla mensa, lavoravo in un gruppo, in equipe anche con una biostatistica, quindi avevo un supporto statistico, ma ero in connessione anche con altre figure professionali. Il mio compito era quello di elaborare dei database, fare analisi multivariate, anche analisi fattoriale, e poi tutto ciò che comporta la stesura di un manoscritto, quindi la redazione di tabelle, grafici, l'invio a una rivista ed eventuali revisioni. Dopo 6 mesi di lavoro abbiamo pubblicato un articolo su Geriatrics Gerontology International, che è uno studio sulla qualità della vita di soggetti con demenza che vivono in case di riposo. Lo studio si è effettuato su 525 soggetti in 14 case di riposo su tutta la Spagna. I risultati hanno evidenziato come non soltanto lo stato della demenza o lo stato di depressione sono importanti nella qualità della vita di questi soggetti, ma anche le frequenze con cui vengono visitati dai parenti, oppure la presenza di un gelato nella struttura, o anche le aspettative che hanno questi soggetti quando entrano nella casa di cura, sono importanti nel determinare la qualità della vita. Un secondo articolo pubblicato su BMC Surgery, che è una review sulla qualità della vita in soggetti con cancro del colon retto. Un terzo articolo accettato proprio questi ultimi giorni sull'European Journal of Internal Medicine, che è stata un'analisi fattoriale condotta su oltre 2800 soggetti per evidenziare quali patologie croniche andavano a influenzare lo stato funzionale di soggetti con più di 65 anni. Sono stati evidenziati 4 gruppi cluster di malattie che più frequentemente si associavano tra di loro, e in particolare quelle che impattavano più sullo stato funzionale erano le malattie neuropsichiatriche. Questi lavori sono stati inoltre presentati sia al Congresso Iberoamericano a Granada, sia come poster, sia come comunicazione orale al 46esimo Congresso City. Questi sono alcuni dei seminari che si vedono male che ho frequentato. Di uno ho frequentato pagando la quota, e quindi ho ottenuto dopo un piccolo esame l'attestato. La professoressa è rimasta molto contenta di questa esperienza e abbiamo continuato a collaborare. Ho aiutato il gruppo di lavoro a scrivere un libro in spagnolo che poi è stato presentato al concorso delle scienze sociali 2013, e inoltre stiamo procedendo alla stesura di un quarto articolo. Questa esperienza mi è stata molto utile, quindi ve la consiglio per chi volesse farla, perché permette di confrontarsi con vari professionisti, ampliare il proprio network e le conoscenze che al giorno d'oggi sappiamo sono estremamente importanti, di arricchire il proprio curriculum vitae, di conoscere persone e culture diverse con cui potersi relazionare, migliorare o apprendere una lingua come nel mio caso, acquisire apertura mentale, ovviamente anche prendere magari maggior coscienza di quello che sappiamo fare e di quello che vogliamo fare, tra virgolette, da grandi. Questo era il gruppo di lavoro con cui ho avuto il piacere di lavorare. Con questo concludo, vi ringrazio per l'attenzione.
Ringrazio io Stefano a nome di tutti. Io credo che la sua esperienza si commenti da sola. Quello che effettivamente ha detto, che ritengo molto importante, è il fatto che bisogna lanciarsi. Lui si è lanciato, insomma, abbiamo visto i risultati di quello che ha fatto. Noi ci stiamo lanciando oggi in qualche modo all'insegna della novità, nel senso che effettivamente non avevamo mai creato un evento di questo tipo, quindi probabilmente riusciremo anche a trarne le giuste in qualche modo conclusioni alla fine dell'intervento, però effettivamente è un piacere poter ascoltare le esperienze di questi colleghi, che possono essere, insomma, fonte di ispirazione. Secondo me anche l'esperienza del collega Raffaele Palladino potrebbe essere degna, insomma, di essere ascoltata. Il collega invece è andato a Londra, sempre con una internship di EuroNet, ma io non voglio aggiungere altro, sarà lui, insomma, a raccontarvi la sua esperienza.
All right. Good morning, everybody. Good morning, everybody. If everybody agrees, I'm going to talk in English, or at least try, because considering we have like colleagues from other countries. So, as you can see from the template, I'm going to talk about my experience at Imperial College in London. I'm Raffaele Palladino. I'm a medical doctor, public care resident at the University Hospital Federico II of Naples and the School of Public Health. So because it's supposed to be very practical, this intervention, so I'm going to give you a brief introduction about myself, so in case you can somehow understand how I ended up being there, just working there. So the School of Public Health in Naples is inside the hospital. So when I was home, most of my activities were strictly related to what we used to do in hospitals. So just to list some of them, I was focusing pretty much on healthcare utilization, so mostly monitoring, evaluation, and appropriateness. So trying to first analyze and then try to fix if something wasn't working properly. Then, especially in the first part of my career, I was focusing on healthcare-associated infections at both internal and external level. In fact, surveillance, also the international one that headed to ECDC and prevention with guidelines trying to implement, with a special focus on the surgical vein infection. And then some clinical risk management. And in the last part, and it's starting to be like pretty much my main interest, monitoring risk factors and clinical progression of chronic neurological disease, especially Parkinson's disease and multiple sclerosis, and studying the epidemiology related to healthcare utilization. So, but this was enough for me, but I wanted more. I want to be more involved in research. So I wanted to move somewhere else in Europe for an academic placement. My idea was UK, just to improve language, and also because economically speaking, they're quite a wealthy country, so they have much more possibilities, at least comparing to Italy. So when I asked it, it wasn't updated yet, the list. So I had to ask to the Italian committee to help me rather than going directly to the website. So I asked them the list of the UK placements. They gave it to me. I went directly for the academic placements, especially in London. I wanted to be there. So there were basically two academic placements. One was the London School of Hygiene and Tropical Medicine. It's pretty famous worldwide. And then the Imperial College. Both were amazing, but I have to say I went for the Imperial College because the London School was pretty much focused on the infectious disease epidemiology. I wanted to switch to something else, sorry. So Imperial College listed among the activities tobacco control, diabetes network. So it was more about public health at like wider glance. So I asked my colleagues to somehow make me in contact with someone from Imperial. They were nice, very, very willing to help. They did it immediately. So they contacted Dr. Chris Millett, the Deputy Director of the Master of Public Health at Imperial College. It was extremely nice to me. We first started exchanging emails, and then we had a couple of Skype calls. But this is funny because it was August. I was on holiday, and it was like, can we make a Skype call within the next few days? I was like, yes, but it might be a bit, I don't know, problematic, but it was just fine. And we did it in the first days of September, and it was just very, very quick. He understood that I wanted to be there as soon as possible, so only in 2 months it was done. So I decided to go for the School of Public Health at Imperial College. That is very, very famous, and it's huge. The director is Elio Riboli. He's Italian, but pretty much famous worldwide. He has been very active in all the genomic studies and preventive medicine. And the aim of the school is to achieve better health in the population through strengthening the public health science base, training the next generation of public health leaders, and influencing health policies and programs around the world. As I told you before, the school is huge, and Imperial College has two main campuses, split into two big hospitals in the city centre. One is at Charing Cross Hospital, so the Charing Cross campus, and the other one is at St Mary's Hospital. Even if there is somehow like a difference between the two, because the first one, the Charing Cross campus that is in Hammersmith, it's more related to clinical disease, or at least like primary care and public health. In fact, you have the Department of Primary Care and Public Health, the Neuroepidemiology and the Aging NEA Research Unit, and Genomics of Common Disease. The other the other departments, the other part of the school, it's at St. Mary's campus. I have to say it's probably the part that made it famous, but it's more about biostatistic, epidemiology, like pure level. So it's pretty much about math and methods modeling. In fact, you have the Department of Epidemiology and Biostatistics. Infectious disease epidemiology is the department that made it very famous with all the modeling about the infectious disease. And then you have the clinical trials unit. Of course, I went for the Department of Primary Care and Public Health because I wanted to be more in research, but I wanted to stay in my field. So that was my obvious choice. The director is Professor Azim Majid, and the aim is to promote research into primary care and public health that can be applied to improve health in human population. This department itself is very big, and it's also perfect if you wanted to be there and not only be in research, just to like breathe this very inspiring environment, because they also manage so many at different levels all the lectures for the academia part. So they have they manage the master, the MPH, the Master of Public Health, the MSc in Epidemiology, and undergraduate teaching. But also they have several units. So the Health Services Research Unit, that is pretty much about healthcare utilization. Then you have the Dr. Foster Unit, that is more about the patient safety, so implementing guidelines. The child health, well, you can guess from the title. Then undergraduate teaching, education. And then they have two last sections that are part of the WHO. So even if they are part of the department, but somehow they are separate, but it's still nice to be there because they have delegates from all around the world every day. You can share any information, you can keep updated about also middle, lower income countries. It's very important. There are e-health units and the proper WHO collaborating center. But just to be very practical, the projects I have been involved in, they were very, very nice because they started at levels. Because I went from the hospital, the first project was very much related to typical activities I had been involved in at home also. It was part of projects funded by the NIHR and Clark. It was about quality and quantity control. So monitoring of GP services prescribing habits of specific drugs within GP services of the whole country. So basically they isolated few drugs related to a specific disease and studied the habits, the quantity of prescribing, and started to evaluate with analysis. So in the main analysis we considered prevalence rate of the disease related to these drugs, population factors, primary care performance, and index of multi-deprivation RAM. For people here are not familiar with it, it somehow describes the level of that specific part of the country in terms of healthcare service, in terms of wealth, and so on. So this was the first project. I'm not going to tell you details because it was just not long time ago. I left country and they have just submitted it. So finger crossed about how it's gonna be. And another project is more about public health at wider level. So it's association between active travel and health outcomes in low and middle income countries. As you can see from the title, we switched completely. So a study on the low and middle income country. I wanted to be more involved in this in terms of health inequalities and preventive medicine. This specific project was part of a wider group of projects involving the physical activity. It was a cross-sectional study. I have to say, if you wanted to be there, even if they are very willing to help in any case, you somehow have to be proficient in data or at least some statistical package. You can even learn there, but it's easier because these data sets are huge, so you have to deal with them and then run the analysis. They have like a complete group of statisticians can help you, but usually they are there just for consultancy rather than running the analysis for yourself. But the experience, it was only 4 months. I have to say, I didn't mention before, it was from October to March. It was brief, but still full of things to do. So not only my personal projects, but there was also other academic activities. So you can attend weekly seminar about public health projects, weekly biostatistics seminar. The first one, I have to say, very interesting is because they kept you updated about what was happening in the country constantly. The weekly seminar were about like physician or other doctor came there just to talk, to tell you about this project. It was a very good moment just to exchange thoughts and experience and trying to implement it as well. So weekly biostatistics seminar. So in case you wanted to improve your statistics skills, even if you're a physician, but it's still a very good thing to do. Journal club with the PhD student and the PhD group. So not only with your group, but also with others from other units. So it was always nice, very important moment just to exchange thoughts and points of view. And also, of course, within your unit or also others, you could attend a research group meeting, usually every 2 weeks, but it depends. But then you don't really have only to attend things at the Charing Cross campus, but also at South Camp, that is the main campus of the Faculty of Medicine, where there you could go and attend seminars, events of anything, and then also to all postgraduate lectures. So it was very lively, very active in these things. And also, public health is such a wide, topic. So you could just choose what you are more interested in and just go and follow. And also create your contacts. That is very, very important. So, but because it's going to be very practical, or at least I try this presentation, I'm going to give you if I have to list positive aspects about it, it's hard, but if I have to list them, first I have to say working environment. So it was multicultural, and from so many kind of background. You had from physician, biostatistic, epidemiologist, you had psychologists, so any kind. So you could just share information and background with all of them, all very willing to just help you with this. Then also, as you said, the department had several units, so you could go in the unit you were pretty much interested in, or even collaborating with your units. Why not? It's an option. Then also facilities. Well, maybe for people abroad, it's something that doesn't really impress. But I came from Naples. We are not exactly famous for our wellness. So it was just having your desk, your space, everything you needed. It was just, at least for me, a plus. It helped the quality of work, certainly. And then also the London life. Well, here I chose a picture just showing beers, but really the city is lively, vibrant. You have all things to do, and so yes, if you like it, I recommend it. But also negative aspects. Well, they are not really negative, but I have just let's say warning. So first of all, the cost of living in central London, as my colleague before said, you have to go using your own saving. And for me, I kept my scholarship from home. And if you just think of the difference in terms of currency between Italy and not only UK, but London, it was difficult, but still, I wanted it. I had savings, so I don't regret anything. And also, this is not a negative aspect, but just a warning, because you have several units, so you don't really have to. You have to be careful what you are going to choose, because some projects can have not the clinical part as main focus. So it can be focused on health economics, econometrics, data analysis, biosocial. You can go there, why not? But just be careful before you decide to get involved in something that is something that really interests yourself. Well, what's next? I was there from October to February with a honorary clinical research fellowship. But they were so nice because we started working very well, so they extended the honorary for other 2 years. In fact, from Naples at least, it's very easy to reach London, 5 flights per day. So I keep going, it's easy. When I have like 3-4 days, I can somehow manage to go. I go there, we keep working and talking about future projects and so on. Also, I'm going to come back there because it was very easy, thanks to EuroNet, that I already had the contacts. So I created this placement, academic placement for an Erasmus scholarship. It's going to be for 6 months, starting from September 2014. I'm going to write down my thesis. It's going to be about elderly people, healthcare utilization, and all the risk factors related to it. And what's next? One of the projects I was involved in has been accepted as a oral presentation at UFA, so I hope to see some of you there, or why not even all of you. If so, I'm happy to, I don't know, meet there or just down to exchange thoughts. Well, I'm gonna leave you with this image. It might be a cliche because it's central London, but it's probably my favorite place in the city. It's taken from the St. James's Park. It's the park close to Royal Palace. It's lovely, it's my, I don't know, especially in the sunny winter days, it was my piece of heaven there. So thank you, everybody.
Ringrazio il collega Raffaele Palladino, che tra l'altro è anche il vice coordinatore della consulta, segretario della consulta degli specializzandi di Igiene, con cui chiaramente c'è una partnership che ci ha in qualche modo anche permesso di organizzare in contemporanea le giornate degli specializzandi e un meeting di EuroNet. Tra l'altro il collega è stato così gentile da mettere anche a disposizione casa per ospitare 20 persone che in qualche modo facevano una riunione durante il sabato, quindi lo ringrazio anche personalmente. E visto che siamo un po' fuori tempo, io lascerei la parola a Salvo Parisi per moderare la prossima sessione. E potremo fare le domande anche ai colleghi che sono intervenuti subito dopo questa sessione. Grazie.
Grazie Guido per la parola. Io sono appunto un altro collega di Palermo, Salvo Parisi, membro di EuroNet. Prima di iniziare con la mia moderazione, però vi chiederei 2 minuti, scusate, anche molto di meno, perché vorrei provare a far ritornare in linea Parma, visto che mi dicevano poco fa aveva qualche difficoltà tecnica.
Eccoci.
Perfetto Anna, è davvero un grandissimo piacere sentirti e vederti adesso.
Buongiorno a tutti, ci vedete, noi siamo un gruppo misto fra studenti di medicina laureandi nelle prossime settimane, specializzandi, la quota più rappresentata di igiene, ma abbiamo anche specializzandi in medicina d'urgenza e medicina del lavoro. Vi sentiamo e vi vediamo piuttosto bene, stiamo facendo questo esperimento, siamo molto contenti di partecipare, vi abbiamo introdotti prima per l'esperienza che abbiamo noi come specializzandi in igiene, che conosciamo voi, alcuni personalmente, che conosciamo EuroNet, e ci stiamo preparando questa mattinata, eventualmente interagire con voi dopo se gli studenti e gli specializzandi avranno qualche domanda sugli interventi che sono stati fatti o che verranno fatti dopo. Rimaniamo qua e vi seguiamo con interesse.
Io volevo soltanto dire una cosa, perché volevo approfittare, dopodiché andrò via, del fatto che, visto l'interesse che questa manifestazione sta suscitando, e mi sembra che sia una manifestazione veramente utile proprio per quanto riguarda gli scambi culturali che ci sono, la prossima occasione, per questo approfitto della presenza della collega di Parma, potrebbe essere quella di proporre al professor Signorelli, visto che noi nel 2015 abbiamo il congresso di Igiene a Milano in collaborazione con IUFA, quello proprio di fare una presentazione nel 2015 dei nuovi che andranno nel frattempo e di riproporre una riunione nell'ambito del congresso di Igiene nazionale a Milano nel 2015 in occasione dell'Expo in collaborazione con IUFA. Era questo quello che volevo dire, proprio approfittando del fatto che c'è il collega Compagni, quindi adesso
è un'ottima idea, noi ci faremo sicuramente messaggeri di questa proposta.
Grazie Presidente della Scuola di Medicina di Palermo, grazie Parma. Io a questo punto andrei avanti con la moderazione della sezione. Welcome again everybody. I would like to start the presentation of the new session of our meeting. So it was a great pleasure first take the floor from Guido Maringhini, my junior tutor in the School of Hygiene and Preventive Medicine, and now coincidence of life, I will give the floor to Palmira Immordino, that is starting the session that is about global health, and that will give us an introduction about her experience. She will talk better about. She went last year to the London School with the London School of Hygiene and Tropical Medicine to do an experience on film in Eastern Africa, to do other diploma in infectious disease, but now she will tell us much more.
Welcome everybody, and good morning. I'm Palmira Immordino. I'm starting my third year residency program in public health, and my apologies to our European colleagues because I'm going to comment my presentation in Italian, since it's the first time I present my experience in Italy. But my presentation is actually in English, so if you have any questions, just ask me. Okay. Okay. Ah, ok. Ok, quindi dicevo appunto io sono Palmira Immordino, ho appena iniziato il terzo anno di specializzazione in igiene e medicina preventiva. Prima di cominciare dei ringraziamenti innanzitutto alla mia tutor, la professoressa Casuccio, che mi ha supportato dall'inizio di questa, da quando ho deciso di fare questa esperienza fino al giorno prima della partenza. Poi un ringraziamento al direttore della scuola di specializzazione, la professoressa Mammina. E un ringraziamento speciale al professore Vitale, presidente della scuola, che era appunto presidente della scuola, direttore della scuola di specializzazione quando io sono partita, quindi quando ho iniziato questa esperienza. Allora, innanzitutto sono partita lo scorso agosto, ho fatto un'esperienza di 3 mesi, da agosto a novembre. Ho frequentato un corso in malattie tropicali e igiene dell'Africa orientale. Perché ho scelto di frequentare questo corso da igienista, da futura igienista, specializzando di sanità pubblica? Perché per chi come me ha deciso di intraprendere il percorso formativo in sanità pubblica per lavorare in futuro nella cooperazione internazionale. Il programma di questo corso ha risposto alle mie esigenze di formazione e di approfondimento dell'epidemiologia delle malattie infettive, ma in generale di tutte quelle problematiche che i medici che vivono la realtà appunto dei paesi in via di sviluppo devono affrontare praticamente ogni giorno. Il corso diciamo, è storicamente presente a livello europeo, è offerto dalla London School of Tropical Medicine and Hygiene e dall'Università di Liverpool. Diciamo che appunto quello che mi ha, diciamo che mi ha portato ad applicare per questo corso è stato la possibilità, oltre a approfondire appunto da un punto di vista epidemiologico le malattie infettive, le malattie tropicali in particolare dei paesi in via di sviluppo, anche la possibilità di conoscere tutte le problematiche di sanità pubblica in paesi a risorse limitate. E il fatto che diciamo che tra le più importanti organizzazioni non governative, come ad esempio Medici Senza Frontiere, diciamo un background di questo tipo, un diploma, comunque un corso in malattie tropicali di questo tipo ha un forte impatto nella valutazione dei curricula nel momento in cui si decide nel futuro appunto di voler collaborare con un'organizzazione non governativa che si occupa di cooperazione sanitaria internazionale. Diciamo appunto è un corso di 3 mesi che come dicevo appunto io ho svolto attraverso appunto la London School of Hygiene and Tropical Medicine, che diciamo per chi non dovesse conoscere è un'istituzione a livello mondiale per quanto riguarda appunto la sanità pubblica, l'igiene e la medicina tropicale. Da questa scuola infatti diciamo, sono venute fuori delle figure che adesso ricoprono posizioni di grande rilevanza e in oltre 160 paesi in tutto il mondo, a livello dei ministeri della salute, a livello di università e organizzazioni internazionali. Diciamo che il corso che ho frequentato io esiste storicamente, è offerto storicamente dalla London School e diciamo che viene fatto a Londra, dura anche questo, quindi 3 mesi. Ciò che cambia è stato che diciamo che il corso che ho frequentato io è stato invece per la terza volta riproposto diciamo in un contesto africano, ma va a riprendere esattamente quella che è l'anima del corso che si trova appunto, che viene svolto a Londra. Diciamo questo corso però nasce dalla collaborazione in realtà di 5 istituzioni di 5 paesi, infatti appunto è un corso che nasce dalla collaborazione tra la London School, ma anche la Johns Hopkins University, l'Università di Washington, il KCMC, che è appunto la Kilimanjaro Christian Medical College University, e la Makerere University, che è l'università di Kampala, la capitale appunto dell'Uganda. Allora, diciamo che quello che innanzitutto il corso, le 5 istituzioni che hanno voluto fortemente questo corso hanno, diciamo, hanno avuto una ricaduta secondo me assolutamente diretta sulla filosofia di questo corso, che io ho definito in un certo senso una filosofia globale, quindi un approccio globale che va sia appunto dalla partecipazione, quindi diciamo gli studenti che frequentano questo corso, ma anche diciamo il corpo docente, che appunto proviene praticamente da queste 5 università e che sono, diciamo, si tratta di professori che hanno comunque avuto esperienze lavorative in Africa o comunque hanno vissuto in Africa per un periodo della loro vita. quindi diciamo proprio lo scambio sicuramente di la possibilità quindi di avere una visione a 360 gradi della salute praticamente proveniente da tutti gli angoli del mondo, gli studenti stessi che provengono dal Canada alla Nuova Zelanda, al Giappone, con cui io avevo colleghi assolutamente provenienti da tutto il mondo, ma l'approccio globale secondo me sta anche nel diciamo del razionale di chi ha voluto fare questo, chi ha voluto così fortemente riproporre questo corso in un contesto africano. Questo perché appunto tra i miei colleghi, ne eravamo in 60, 20 di questi colleghi erano colleghi che provenivano dall'Africa orientale. Questo perché appunto un terzo di tutti i posti viene riservato a medici africani e attraverso parte delle nostre tasse di iscrizione sono utilizzati proprio per finanziare delle scholarship per questi colleghi. Questo fa capire come la London School e le altre istituzioni vogliano investire davvero o comunque vogliano creare le basi per quelli che saranno poi in futuro diciamo, i medici specialisti insomma, di salute pubblica, ma sul campo, quindi anche ovviamente i medici africani. Per quanto riguarda i criteri vengono valutati al fine di essere comunque selezionati per questo corso, viene innanzitutto necessaria ovviamente una laurea in medicina e una abilitazione alla professione, ma viene anche richiesto di scrivere un articolo breve sulla crisi di risorse umane in Africa, che viene valutato insieme al curriculum del candidato, e ovviamente bisogna avere un ottimo livello di conoscenza della lingua inglese scritta e parlata. Allora, andiamo più sull'organizzazione del corso. Diciamo che le prime 6 settimane vengono svolte in Tanzania, in particolare vengono svolte a Moshi, dove si trova la Kilimanjaro Christian Medical College, che diciamo ospita la prima parte, dove appunto avviene la prima parte del corso. È diciamo, da un punto di vista di localizzazione, comunque si tratta di un posto splendido che si trova sulle pendici del Monte Kilimangiaro. Qui viene svolta sia la parte di lezioni che la parte di laboratorio e di frequenza dei reparti. Il programma del corso consiste fondamentalmente in lezioni giornaliere che vengono poi raggruppate in aree tematiche dove si affrontano, in alcuni casi vengono divise in settimane tematiche in cui si affrontano diciamo, temi maggiori, in particolare tubercolosi, malaria e HIV. Ma comunque diciamo che viene dato ampio spazio a tutte quelle che sono le infezioni, le malattie infettive, ma le infezioni sessualmente trasmesse, le malattie tropicali dell'occhio, la dermatologia e la neurologia. Ovviamente alla base diciamo vi è una forte base di epidemiologia a 360 gradi applicata a tutti questi campi, però una prima parte del corso, le prime 2 settimane, sono proprio incentrate sulla epidemiologia delle malattie tropicali, con la possibilità anche di esercitazioni, simulazioni di investigazioni di epidemie, che ho ritenuto essere comunque anche la parte più interessante. Per quanto riguarda diciamo, le settimane tematiche, queste appunto vengono nella prima fase del corso si ha una settimana in cui ci si occupa di malaria diciamo, dalla fisiopatologia, dalla microbiologia, alla fisiopatologia al controllo, alla prevenzione, quindi della malaria, ma ciò che sicuramente è più interessante per noi specializzandi appunto di salute pubblica era la possibilità di simulare praticamente giornalmente dei vari scenari per esercitarsi proprio a avere a che fare sia con i decisori politici, quindi nelle campagne di eliminazione, quindi per discutere appunto di campagne di eliminazione della malaria, sia con avere fare i conti anche con le risorse economiche, nel senso letterale del termine. Per quanto riguarda invece HIV e tubercolosi, queste due grandi tematiche sono state affrontate in realtà in Uganda. È quello che diciamo, pensato potesse essere utile presentarvi è l'IDI, che è appunto un'organizzazione che lavora all'interno del Mulago Hospital, che è appunto l'ospedale universitario di Kampala, che allo stato attuale, diciamo, rappresenta una perla all'interno del sistema sanitario ugandese, perché appunto oltre a offrire servizio ovviamente di trattamento dell'HIV e della tubercolosi, diciamo che garantisce anche la formazione di operatori sanitari, quindi rappresenta anche da un punto di vista di formazione comunque un punto di riferimento importante. Noi avevamo la possibilità di frequentarlo praticamente tutti i giorni, abbiamo lì effettuato pure gli esami di fine corso. Per quanto riguarda le altre esperienze durante questi 3 mesi, sicuramente quello che merita attenzione è la possibilità di fare un'esperienza di lavoro sul campo nella grande tematica della barriera all'accesso, barriere nell'accesso appunto ai servizi sanitari. Avevamo la possibilità di scegliere diverse tematiche. Avevamo la possibilità in realtà di dare delle preferenze. Io sono stata fortunata perché ho avuto la mia prima scelta, che era un progetto, quindi non tanto sulla difficoltà nell'accesso ai servizi nel classico, nell'accezione classica, ma piuttosto la barriera per gli operatori sanitari, nel senso che la mia settimana di rural placement si è svolta a Mwanza, che è una città sul lago Vittoria, dove abbiamo deciso di realizzare un progetto per dimostrare come 8 medici senza alcuna esperienza di diagnostica ultrasonografica possono realmente imparare le tecniche di valutazione nelle emergenze di un paziente politraumatizzato, con ovviamente delle risorse limitate come possono essere un solo ecografo. Questo perché l'impatto di questo è stato evidente dai risultati di questo progetto, che poi abbiamo presentato al resto della classe al rientro a Mosci, e che peraltro stiamo provando anche a pubblicare. Stiamo scrivendo un articolo per vedere se riusciamo a pubblicare i risultati di questo progetto, perché abbiamo valutato come in una sola settimana le nostre capacità di diagnosi siano migliorate tantissimo, facendo un questionario prima e dopo, e quindi come questo possa essere speso anche per quello che viene definito il famoso task shifting, che in Africa è una cosa importantissima, cioè la possibilità di trasmettere anche a operatori sanitari non necessariamente medici, per la mancanza appunto di risorse umane, il nostro sapere, e questo appunto era un esempio pratico di come questo può essere fatto. Una settimana è stata dedicata alla parassitologia, quindi abbiamo passato una settimana in laboratorio, e questo risulta evidente quanto possa essere importante il laboratorio nel percorso formativo di uno specializzando in salute pubblica, perché conoscere bene il ciclo vitale di un parassita permette davvero di capire in che modo prevenire quella determinata appunto malattia infettiva, e quindi qual è la tecnica di eradicazione e di eliminazione più efficace. Infine è stato possibile per noi studenti inviare un abstract di 250 parole prima della partenza. Ne sono stati selezionati 9. Praticamente è stato durante una giornata in cui appunto si è avuto la possibilità di presentare il proprio lavoro. Io ho avuto personalmente l'opportunità di presentare un lavoro che avevo iniziato l'anno scorso qui a Palermo, perché appunto il mio abstract è stato selezionato, che riguardava appunto la malaria negli immigrati VFR. Non so se avete mai sentito parlare di questo appunto di questa categoria di immigrati, quindi diciamo che è stato per me anche l'opportunità di confrontarmi anche con colleghi su questo tipo di malattia che per noi appunto non è così tropicale magari come potrebbe sembrare alle nostre insomma, latitudini. La seconda parte del corso si è svolta dopo una settimana di pausa in Uganda, dove sono stati trattati diciamo, le tematiche relative anche a malattie cronico-degenerative, quindi cancro, salute mentale, le emergenze, ma soprattutto le cure palliative, tutti degli aspetti che solitamente forse non sono i primi aspetti a cui si pensa quando si pensa di lavorare appunto nei paesi in via di sviluppo. Anche qui abbiamo avuto la possibilità di scegliere in base a delle tematiche un periodo in cui ci siamo spostati da Kampala, che è appunto la capitale dove si è svolto la seconda parte del posto, e in particolare io ho diciamo, trascorso la mia settimana a Jinja, che è una località turistica appunto al nord dell'Uganda, dove abbiamo praticamente messo su diciamo uno studio sulla conoscenza dei viaggiatori internazionali in Uganda, circa appunto sia i rischi infettivi ma anche non infettivi. Abbiamo somministrato questi questionari ai turisti che riuscivamo appunto a contattare in giro per la città. Abbiamo appunto fatto un'analisi dei dati e presentato i nostri risultati al rientro anche questa volta. Tutto questo alternato a delle lezioni sulla medicina dei viaggi e sulla gestione delle emergenze che venivano fatte durante la mattina. Infine l'ultimo grande blocco, l'ultimo grande modulo del corso era incentrato sulla salute materna e infantile. Abbiamo avuto, oltre alla possibilità di avere lezioni da appunto, docenti universitari, anche diciamo, si sono alternati dei seminari tenuti da colleghi che hanno lavorato per organizzazioni non governative, ad esempio sulla nutrizione, una collega che ha lavorato con Medici Senza Frontiere, e poi ho avuto la possibilità di conoscere personalmente la realtà dei traditional bird attendant, che sono appunto chi si occupa davvero dei parti nelle comunità rurali che non hanno la possibilità di accedere ai servizi, quindi agli ospedali, e quindi appunto conoscere anche questa realtà. Il modo in cui ci hanno presentato è stato quello di condivisione anche in questo caso, e non di sostituzione, quindi di comunicazione, perché è anche il modo più efficace per raggiungere comunque quello che tutti vogliamo, che appunto sono appunto l'abbassamento della mortalità materno-infantile. Io ho finito, in realtà ci vorrebbero tantissimi altri minuti per parlarvi di tutto l'aspetto umano che credo perda anche tanto valore, forse, essendo semplicemente raccontato. Però l'unica cosa che voglio dirvi per concludere è che quello che mi ha lasciato questo corso è stato esattamente quello che il mio professore, il professore Philip Gottfried, mi ha detto il primo giorno, cioè che comunque le relazioni umane che io ho instaurato durante questi 3 mesi sono importanti esattamente tanto quanto la medicina che io ho imparato. È tutto qua, grazie per l'attenzione.
Grazie Palmira per la tua presentazione. So, before calling the next colleague that is going to introduce her presentation, I would like to spend some few words more about global health and about the reason that we have to, the reason because we have chosen this subject as a topic of our meeting. So, well, global health for a future public health professional is one of the most important field of study and even of work. I could spend plenty of words about the definition of global health because it's also a modern and new field of work, as already said. But what we think is that the best way to understand is to do, whenever it's possible, of course, have an experience on the field of work. And for those that can't, unfortunately, doing or are thinking to do that, the best way right now is to ask to the colleagues to share their experience and to listen to them what were their feelings and which were the skills that they will learn after this work. So thank you again to Palmira, and now I would like to ask and call for Rita Samachado, a public health resident from Portugal that right now is doing a master in public health at the University, at the London School of Hygiene and Tropical Medicine. Again, once time more, this university, this school. So Rita, please. Yes, okay. So, well, why I will use this
Just a
pen,
minute.
as you probably already have understood, I'm the one that is the most concerned about the technological issues. So before I asked it to Anna Odone if she was listening to us, but now I would like also to say good morning and welcome on board to our meeting to the University of Modena and Reggio Emilia. They are following us live streaming on YouTube. And well, after that I post even on Facebook, I guess that a lot of fans are also following us. So, if I, here. Okay.
There's a mode I will show you something. When I record something, you can do it like yeah. Yeah. No.
Yeah.
Yeah. You have to do it and then
This is the problem. The fourth point.
it's easy.
Ah.
It's easy.
You can a single page.
No, it's like opening. No, there's an option where you can do
100%. Maybe
Okay, good morning everyone. So as I was introduced, I'm Rita, because for the UK I'm Rita, so that's why sometimes in my head. So I'm Rita, I'm from Portugal, and I'm a public health trainee there. So now I'm doing my master's at the London School of Hygiene and Tropical Medicine, and I'm going to talk a little bit about my experience. Please interrupt me if Salvo allows it, and if you want it, it's fine. And feel free to ask anything, because I'm going to talk about simple things. I'm going to try to give you a little bit of the headlights, everything that I know for now about the masters, so feel free to talk to me, okay? So the motto of the school is improving health worldwide. So for us, as public health trainees, as medical doctors, we are so fascinating about this motto. So I think it was one of the most important things that taught me, like, oh, Rita, you should go and do the masters at the London School. So the general idea about this master is the application form. For some of you, it's when should I start doing my application? So for my personal experience, I would say around March. Why March? Because you have loads of documents that you need to get translated, because most of you are Italian, Spanish, I'm Portuguese, so we have to do our translations. We have to do everything carefully, our motivation letters, think about what we really want from this year at the London School of Hygiene and Tropical Medicine. For that, I should warn you that I would do this with time, carefully. So documents that we need, one of the most important is the one that I'm going to highlight, is the evidence of English. So I think the majority of you know the IELTS, so it's the most known document, and it's not, I would say that it's not, it's a nice exam. It's a nice exam, it's not bad. So do it, and even if you start doing like this in March, you can do it, for example, if you don't have the marks and you need to apply to the school, you can have this and you can do it several times until you have the marks, because you're going to have the marks. So another thing that is important to say about as general idea, it's about the accommodation. By our colleague that was in Imperial, they talk a little bit about London life, accommodation. So the life is really, really, really expensive. So you should try and try to find the best option. So university halls are good. You just need to apply in the during the time frame that they need it. And even that, you have private house, student halls, and even that you have your own apartments, but you should start again early. So
collecting money, I guess you mean.
Yeah, collect money. So the September party is when everything starts. So my master started at the 30th of September, so really at the end of September. And you should think that even if it's a new experience, and we like new experience, and we are young and free and everything, you have to think that emotionally everything is going to change. So you think about that, even the guys. So again, about a little bit about the masters. So I don't know if everyone knows, so that's why I'm going to highlight this. So we can do the masters in public health, and we can do it in a general stream, a health economic stream, environment and health stream, health promotion, health services management, or health services research. For from my experience at the school, I'm doing the general stream, and I think even, for example, you do the general stream and you have a huge interest in economics, you can still do the economics modules. So it's not, I would say it's not, I think you should not focus too much in the stream, because you could be narrowing your way down, and it's better to keep it a little bit broader so you can actually choose what would best suit you. So at the term one, every single of these streams have this ones that I put it in black, so basic statistics, epidemiology, principles of social research, health economics. So we all have this. And when you choose your stream, you can do or issues in public health, health policy process and power, health promotion theory, environmental health. So these are the broader options for the term one. Term two, you have huge options. You have health services, you can do applied communicable disease control. It depends. You can do economic evaluation. It depends on what you really like. For people that are going there, what I suggest is to read really carefully the book that they give us at the beginning. And even that, I should ask some colleagues that have done the modules before, because sometimes we think that the module is something, and when we arrive there, it's kind of not what we think it was. So, and even because sometimes, so as a broader line, people that come there, we are around 180 with the distance learning doing the Masters in Public Health. So around this, so broader figures, we have medical doctors, nurses, we have people from even international relations. So the backgrounds are huge. And for that, they had to keep it everything sometimes simple, sometimes they keep it a little bit harder. So you should pay attention because, for example, if you are a medical doctor and you're going to do the applied communicable disease control, you have that kind of knowledge. So perhaps that module is not going to be so interesting for you as it would be for other person that it's doing it for the first time. So term 3. The modules are really stuck. You don't have that much option. Are really stuck to your general, to your stream. For example, for me, for my general stream, it was practice, principles and practice of public health. As we work, I don't know, but for my Portuguese experience, as I was working in the field for 9 months before starting the masters, the principles and practice of public health are really helpful. But it's something that you are doing in the field, but now you have like all the frameworks and everything that you need, the theory. And it's really important because I think you should get the knowledge and the frameworks and everything, because when you go into work, you will need that. Not only know how to do something. So again, exams, it's important. So we have finals. We just ended 2 weeks ago, and the finals are for the first term modules. And they are quite interesting because we are 100 and something people inside a huge room for 4 hours during 2 days. So it's kind of a nice experience, or not. And the other exams for the other modules, we do it in the end of the term 2 and term 3. But don't think that during term 1 you're not going to do a thing. No, you're going, because we have loads of assignments and things to deliver, and we have our practicals and theories. So actually, at the London School of Hygiene, we have the theories, everyone there, and then we have the seminars, the practicals, and they divide us in small groups. And a really interesting thing that we need to do is our summer project. So summer project, I'm still doing it, of course, because our master's is only going to finish in September. So the summer project is at the minute you are in the school, after like 2 weeks of work, you will have a tutor that it's allocated to you, and then you discuss with your tutor what do you want to do with the summer project. And the summer project it can be a research, it can be a health policy report, it can be a systematic review, it can be actually a broader thing. But the most important is you should pick the thing that you're really you are really interested, because you're going to spend 3 months every single day working on that, so choose it carefully. And then we deliver the summer, and then if you want, for example, if your tutor is not the person that you need for your theme, for example, if you want to do something around environment, and your tutor is like a statistician or something, you can choose another supervisor for your summer project. So you are not well defining that with your tutor. So I guess one of the questions is why we choose the London School, or why I choose the London School to do my master's. So the first time that I would highlight is the importance of networking. So we have people from all over the world. We have academics from all over the world, and the most, I would say, it's the thing that I would take the most from this year at the school is networking. And we know that we are in a global community. So being there and being with those people and being that environment actually tries a little bit to take you up, or how can I explain this? Tries to make you even more comfortable in the global health community, and that's really an advantage. Another one, as I said, is academic diversity. Academic diversity, you should really not be, I should say that they are not good because they are teachers, because sometimes they are not good teaching. I know I'm broadcasting live, but please don't say that I say that. But they are really good academics. And for that, we should go there and try to, if you are interested in one field, go and knock on the door, send an email, oh, I'm really interested in this field, and you know the top researchers that you can know at the school, so it's amazing. And we work with partners worldwide, so they have the Malaria Center, the TB Center, they have the Global Mental Center, and everything is partnerships with other countries, like low-income countries, middle-income countries, so you can actually get a little bit of that experience if you wish to. Okay, so of course I would take photos because I think it's interesting to know personal experience, but only to say that you are in a really interesting environment. You should, we also have a summer ball. If someone likes ball, we also have that. No, but I think you should focus that for us as a personal experience is also something really, really important. Although I only say good things about the school, there are some things that I think we should focus a little bit on. And one thing is our goals. So I think the School of Public Health, so the London School, is interesting if your main goal is global health. And even if it's global health, I think there are other institutions that you should look to their programs, not focus like, oh, I need to do this, I'm going to the London School. No, go and search for other programs, because there are other really good programs, and then you should decide what you want. But keep really your goals as the main drive for everything that you do. And again, as I said, several options. You have the Netherlands, you have the UK, you have France, you actually have Spain, you have Portugal, but you have other options. And even if you want to go a little bit more further, not Europe, you can go to the States. And another one is keep attention on staff. If you really want to do something with someone, just do it, approach them, because they are there for that. So do. I'm sorry. And another thing is look for the projects and areas that you're really interested in and keep the most of it. If you are really interested in something, just go and say, hi, I'm Rita and I'm doing this and I'm really interested in that, and they are always open-minded about it. Thank you for your attention.
Thank you, Rita, for your complete and very helpful presentation about the Master in Public Health at the London School of Hygiene and Tropical Medicine. I would like to ask you, before asking for questions, to wait for the last presentation about the Junior Program Officer. So just to follow the program, and then we can collect all the questions about the speech that we have already heard about our colleagues, and then we can ask, even calling back again Parma and the other schools that are following us. So please take the floor. And Francesca and Claudia, could you please introduce yourself and about your experience?
Yeah, good morning everybody. My name is Francesca and I'm coming from the north of Italy, from Verona.
My name is Anna and I'm coming from the University of Brescia in the north of Italy.
Yeah, please keep going with your while I'm.
We are here to present our African experience.
In an African language, sorry.
Yeah, it's English African style.
Yes.
Okay. Okay, here we go. Yeah, our experience was made with this NGO. Is an Italian NGO, it's the biggest one, and is settled in the north of Italy, in Padova, and established in 1950, and nowadays is present in these countries, 7 countries in the sub-Saharan Africa. Okay, very bad problem, but the characteristic of the intervention of QUAM is a long-term project, because QUAM wants to settle in the field in the African countries, working in activity way with the reality already present in the country. Another important thing is that QUAM wants to train people both in Africa and in Italy, and train in theoretically and practical way. QUAM participates also many scientific studies and research, not only in Italy, but also with the European Commission and in the settle of global health, and wants to also increase the information about global health, both for the students, for the public health professionals, and also for the activity that the QUAM do. And has also the particular passion for resident doctors, yes, and organize the one project specifically for us. It's called Junior Project Officer. That was the program me and that Anna and I done this year. Is the possibility to spend a period from 6 to 12 months in the field of the project, of the core project in Africa, and is possible for the resident doctor of this residency, this specialization, internal medicine, surgery, pediatrics, gynecology, obstetrics, hygiene, and infectious disease, tropical medicine. Not all the specialization have this possibility for the QUAM, because the QUAM guarantee the tutor and in the field to guarantee the information of the for the resident doctor. For the before our departure, we had to participate to we have to follow a course that was settled in Padova. The course we made was starting in September 2012, and we finished it in March 2013, and was made from different modules. And not all the modules are mandatory for each specialization. For example, for the public health residency, was mandatory the module 1 about the world of cooperation, the module 3 about the management of public health in developing countries, and the module 7 about infectious disease.
Before starting to illustrate to you our experience, I think that it's better to have a look on our starting points. We come from 2 different universities, Brescia and Verona, that are organized in the same way, because we have the same internship activities, research activities, hospital management, and local health district activities. But we don't have any course or any program about global health. That's why we decided to contact doctors with Africa, QAM, and these are the reasons, for example, to know and to learn the structure of different health systems, to analyze the strengths and the weaknesses of these systems, and to verify if real changes are possible, to better understand the world of international cooperation, the efficacy and the effectiveness of the project, and to debunking or to confirm the commonplaces about Africa. This is the picture showing you CPET because it's only a symbol to explain you how hard it was for us to make this experience real. Firstly, because we had to deal with the distrust of the professors. Yes, because they didn't know enough about QAM. They always asked us, why you want to go in a developing country, what this experience will bring on your career. And another important question was, is this experience recognized from the Ministry of Education as an activity inside the School of Specialization? And so I had to look for laws and for other documents that demonstrate that this experience is real and is useful to our work in Italy, but even abroad. The second problem was that QAM sometimes had some logistic problems due to the developing country where it works. For example, sometimes the project and the possibility to go as a JPO in a special state of Africa depends on the political situation of this country. It depends on maybe some health threats, and so it depends on the safety for the JPO in this country. That's why sometimes QAM delay in the communication of the period of the departure, or maybe the delay in the communication of the place, the real state, because it depends even on the availability of a tutor available to follow you for all the 6 months. So it was very hard for us. Now, sorry.
Okay, so we are going to explain you the experience. I've been in Ethiopia, and I arrived in Ethiopia at the beginning of August 2013, and I joined the project manager in this project that was strengthening maternal and child health care service at community health center and hospital level. The project was made by Dr. South Africa QAM with other partners like Italian cooperation, Italian government, the Ethiopian Federal Ministry of Health, the EuroNet region where we settled, and the Sanità Hospital, Catholic Hospital, that was where we had our headquarters. It was a 3-year project, and this began at in February 2012, and so I arrived almost at the middle of the project. This is the public health staff, and as you can see, most of part of the staff is local staff. Only the project manager and the accountant were from Italy, and all the staff were Ethiopian. And this is quite necessary because it was necessary because of the problem of the languages and of the communication with the field. In particular, we were settled in EuroNet region, that is the biggest region in Ethiopia, and in the southwest Shoal zone, that is the province, or a province in at about 1 million of inhabitants inside Romania, and the project was settled in the three districts that are Olci, Boiso, and Goro, with a total catchment area of 400,000 people. Okay. The territory was structured in this way. There was the main hospital, the Boiso one, where we said, the peripheral health center, the rural center, like a small hospital, in which there were water and electricity and a delivery room where was conducted the not complicated delivery, a laboratory for blood testing, and OPD service, outpatient department service, for both for children and for adults. More peripherally, there were health posts. Health posts are like a small ambulatory with no water and no electricity, and they were open 2 or 3 times a week, and they were used mainly for vaccination program. Each health post counted a catchment area of about 5,000 people, and there were about 5 health posts for each health center catchment area, and then the health center referred to the hospital for the majority problem. And our project followed 8 health centers and 21 health posts. The main activity was the supervision activity, and there were one supervision for each health center and each health post once in a month. And the supervision was made not only by QAM staff, but also with the government staff from the district and from the region. So this was quite huge to organize every month this kind of activity. Supervision, the aim of supervision was to see the performances from the health center, to focus on the major problem, and also to set the target for the performances for the following month. Another important activity was the one of the training, as I said before, because the QAM stressed very much about training, and the training was organized in Boiso Hospital, both theoretically and practical training for health professional and community workers. Pregnant Women Forum were meeting with pregnant women and at community level, just to focus on the problem of safe delivery and for the vaccination program after delivery. The project supports also technically the health centers, giving them the solar panel for the lack of electricity. We organized market mobilization during the market in the city, in the town, just to promote the free ambulance service for pregnant women. We made nutritional screening just to screen the severe malnutrition and to teach the mothers how to prepare complete meal for the children. All of these project activities were summed up for the activity of data collection. That was the one in which I worked most. Not only for a monitoring point of view, but also for reporting to the donors of the activity. The data collection was done in different levels, both health centers and post-hospital and PH department. We focus on 37 indicators, 2 impact indicators, 12 outcome indicators, and 23 output indicators. And these data were used during the so-called review meeting. There was a meeting made every 3 months with the not only the health center staff, but also with the district government part. to show value the target and what data collection was done. I mean, what is data collection? Because as Africans teach us what is not registered for your firm.
Now I will introduce you my project. As Francesca, I spent in Tanzania 6 months from November, the first week of November of 2013 up to the first week of May 2014. My experience was settled in Tanzania, specifically in a region far, almost 10 hours by bus from the main city, that is Dar es Salaam on the east coast. In the region, there is the major city, that is Iringa city, and from Iringa to the hospital where I worked, it takes 30 minutes by car or by bus. This is the hospital, Tosmagangal Council designated hospital, built in 1968. It belongs to Catholic Diocese of Iringa, but from 2009 it is formally recognized as a district hospital with a catchment area of about 265,000 people. This is a typical example of a public-private partnership. The hospital has 165 beds with 6 different wards. The one staff is composed by 1 pediatrician, 1 JPO in pediatrics, 1 public health expert, 1 JPO in public health, and 1 gynecologist. This is the inpatient department. Then we have a comprehensive outpatient department with adult clinic, reproductive and child health, laboratory, radiology, the TB unit, and so on. I was a part of a big project called Mother and Children First, that is the soul of QAM. And inside this big project, we can see the aim to enable access to improve the mother and child health services in Iringa District Council and Mufindi districts that are 2 parts of the Iringa region. Among these projects, my task was to work on the evaluation of the quality of the assistance inside the hospital. So I spent my time in the improvement of data collection and analysis. Sorry for the picture, but it is here to show you that the main problem was the underestimation of the new access in the hospital and of the second visit in the hospital. In the register, there was the lack of information, for example, the lack of date of admission, the lack of date of discharge, the lack of date of death, and so it brings to an overestimation of the average stage in the hospital and an overestimation of the bed occupancy rate. So we try to find a new solution, for example, to organize the audit with the health workers, with doctors and nurses to understand where the problem was in the chain of collection of data. And another solution was to try to improve the data analysis using a new data collection system, or to make a comparison between different data sources to identify where the errors were, in again training of the staff. Another important project inside the monitoring of quality indicators, inside the other project, sorry, was monitoring of quality indicators. These are the main indicators that we checked every month inside the hospital. For example, the total admission in children under 5 years, the number of deliveries, cesarean section rate, and so on. And we discuss monthly these indicators in order to elaborate new strategies to strengthen mother and newborn healthcare services. This is an example of the project Mother and Children First on the website of Doctors with Africa One. And these are some data about these indicators. In this hospital, we observed almost 3,000 deliveries per year. The cesarean section rate, unfortunately, is very high, 32%. The perinatal mortality rate is around 50 on about 1,000 newborn, and the maternal death in 2013 was 5. All these data were elaborated and collected in this document that is the quarterly hospital report. We presented this report every 3 months to the bishop and to the other local authorities. It is a very important instrument to discuss and to create the awareness of the problem of the hospital, both in the staff, but even in the local authorities and the bishop. Inside the project of a mother newborn care continuous quality improvement team, my activity was inspection and supervision inside mainly the maternity ward to guarantee the condition of hygiene and about the structure of the ward. So we observed in the lowest picture you can see, for example, the incinerator or the method to wash the hands in the right picture, because we have a basket with water and a basket with water with soap. And this is the condition. These are the conditions there. Another important project, my favorite, was that born from the project cooperation agreement between UNICEF and PUAM, ensuring care and support to malnourished children in Iringa and Giova region. This project duration was 2 years. The beneficiaries were the under 5 children residing in these 2 regions, Iringa and Giova. These 2 regions represent an area as big as the north of Italy. Only to explain you. And the expected impact was to contribute to the reduction of mortality associated with severe acute malnutrition in these regions. So with this project, we expected to increase the access and coverage of severe acute malnutrition treatment in 9 major hospitals, in 25 health centers, and in 13 dispensaries by 2015. We estimate to treat almost 3,500 children with this disease, and we expected to train a lot of community health workers and doctors and nurses to manage the severe acute malnutrition in the hospital, but even in the health center, to make them aware and able to screen these kind of children and to refer malnourished children to the biggest and to the regional hospital. So in this project, my activity was to participate to the need and bottleneck assessment in 5 selected hospitals for these 6 months, but the total hospitals were 9. So I went in this hospital. We showed the project to the local authorities. We looked for an area inside the hospital to build up the new malnutrition unit, and we investigated the management, the usual management of the malnourished children in that hospital. After that, we organized the training activities on inpatient and outpatient therapeutic care of severe acute malnutrition, and even on inpatient and outpatient health workers. For example, here you can see the nurse on the left that is learning how to weight the child, or in the right side how to take the length. That are 2 important indicators to identify this kind of children. This is the malnutrition unit that we created in Tosmaganga Hospital. I'm proud of this unit. You can see that there are very simple elements inside, but they are very important for the treatment of these children in developing countries. For example, the cooker, the pan, the fridge, and the specific powder milk at 100 and at 75. This is our tool inside the ward, the pediatric ward. We use this file, we took this file from the Tanzanian guidelines that make it possible to collect information about these children and about their outcome after the recovery hospital, and that make it possible to create a database, specific database to collect the clinical information of these children. After this project, I followed another project about district activities. I made the supervision of 8 health centers in the district of Iringa and Mufindi, and even the supervision and check the knowledge of the pregnant women after their training about the risky pregnancy and the risky symptoms of the pregnancy. For example, we train them about eclampsia and so on. And these are some pictures. This is an health center. This is a picture of our supervision. We basically go looking for pregnant women in the village, and we ask them some questions about their knowledge about their pregnancy. This is another picture about this, and thank you for your attention. Apologize for my English.
Thank you, girls. Thank you. I'm not sorry before I run before your name. I will apologize also. So, well, I would like to call Guido to come back to the floor to co-share with me the discussion. So, if there is any question about our presentation, I would like to remind you that we, with Guido, had before a topic on the experience, the international health electives experience that the residents in public health have done with the help of EuroNet. And the second, it was about global health and even actually about the master in general public health, and lastly the presentation of our colleagues about the junior program officer. So we'll already know that Raffaele probably has something to ask. If you would like to even come here or just use our microphone and ask your question, please.
I do have a question for Rita, so hope she doesn't misunderstand me just an occasion, because I keep having this argument debate with my colleagues, so it's just an occasion to hear your thought about it. It's just about why the Master of Public Health for a public resident. Well, I'll try to explain better myself. Why would you recommend it? Because do you wanna move abroad to do a PhD or to work in academia? Or do you still recommend it even if you plan to come back? I mean, like, it pretty much covers all topics you're going to cover in your specialty program, right? But it's held by very famous people, let's say, and they're very, very good. But still, if you plan to come back, why choosing the MPH rather than, for instance, the MIC in epidemiology, for instance? They can give you different skills, like different items, like tools, whatever. It's just because I have like so many, sorry.
It's just that the question is really clear, and I think that Rita already knows the answer. It's just because I know the answer as well, so I think that she can give us the answer. It's just that we ran out of time, so okay. Sorry if I have to stop you here.
Okay, so I'm going to be really. Thank you for your question. So my opinion is that you should do. I think you should do the Masters in Public Health. I'm not saying you should do it at the London School of Hygiene and Tropical Medicine, but I'm saying, yeah. So I'm saying you should do the Masters in Public Health. Just because it gives you not sometimes an epidemiology field background, as you were saying, but give you a little bit of an experience in public health. And even sometimes you think, oh, I know this, I know that, but it's different to actually have that kind of knowledge and people tell you something about it. I think it's worth it. I'm not saying it should be at that school, but I think it's worth it.
Are there other questions? Ci sono altre domande? Volevo solo aggiungere, insomma, per chi non avesse capito, che effettivamente il Master in Public Health in alcuni stati viene in qualche modo incluso nel percorso della specializzazione, quindi effettivamente in alcuni paesi quello che avviene è che durante il primo anno il Master in Public Health è quello che loro fanno, così come in Spagna e in Portogallo, quindi in alcuni casi è possibile farlo direttamente all'estero. Vedo che il collega ha una domanda, quindi se gli possiamo passare il microfono, perfetto.
Hi to everyone. Congratulations for everyone for your speeches, and I was interested in the QAM projects, so I have a question about that. You said at the beginning that QAM do a lot of things. One of the most important things I think is the training part, when you train people in improve their condition and techniques and the prevention of eventual errors or the creation of bad condition, health condition. But one of the aspects that I wanted you to explain me better is the research part of QAM. If there are research projects that are already finished with some kind of results, what type of research do in the countries? If the research part is the example you explained of, or if there is another type of research, more I don't know, epidemiology or something else. Thank you.
I will begin and Anna if to add something. The research part is made at different level because there is a headquarter in Padova, and they have a monitoring program for all the 7 countries that I showed. So there is a special office, I mean, for the project management of all the projects. So they conduct also research for compare all the projects in different countries. For example, they finished last year a big research about quality and for the inequality of health service, comparing, for example, the Tosamaganga, Woliso, and other reality. In the field, I mean, for example, for Ethiopia, we made research in particular with the Ethiopian government. So, for example, the Ethiopian government asked us to participate at for as a research for the use of ambulance service, if it could be useful to improve the free ambulance services, the impact of ambulance services could be useful. Now is starting a research for the impact for a future vaccination for HPV, okay, HPV for the young women. So, I mean, there are many fields and many partners, and is not the one in Padova is for supervising all the projects, but if each project has his kind of research, so it's very huge.
There is another question there.
I agree with Francesca, but I want to add that if you want to, if you have some ideas, you can ask to the scientific group in Padova to perform a research by yourself, or even to utilize your data that you collected during the experience after to make maybe a thesis for the specialization and so on. So you can even find some articles in PubMed. There are some patient satisfaction surveys about Ethiopian hospital, but I think that even for the project about malnutrition, soon we will publish something.
Hello, my name is Liliana and I come from Portugal. I would like to ask a question and to make a comment, if it's possible.
Yes, please.
First of all, thank you everyone for your talks. It was a very interesting morning with all of your presentations. Secondly, about the QUAM project, I would also like to ask you. We work in developed countries, so and probably the majority of the residents will continue working in a developed country. So, although I would love to work outside Europe, it's one of my dreams, I would like to ask if how does your work in Africa or Asia or whatever part of the world is, how do you think that the work in a developing country will affect or will have an impact in your future career in a local unity in your country? Well, in this case in Italy, but it could be in Portugal, it could be in France, anywhere. Is it just a way to practice the skills that you learn throughout your course? Is it a way to practice research? Is it a way to get something published? Or I mean, how can you apply your knowledge, the knowledge that you gained from your experiences abroad in the field when you have to deal with an Italian population, for instance?
I just would like to ask to have a short answer because we ran out of time, so just be concise, please.
Okay. Very short. I think it would be very useful, not only for the skills, that are actually not much huge because, for example, also the practical skills for Excel and for this kind of program were not so present. I mean, for the but it's used for project thinking. I mean, you learn how to understand what is important, what is not important, what are the data that you need, how they can collect, and the method, the right method. I mean, I began from the beginning, the data collection, because actually when I arrived, it was 1 year of the project, but the data collection was not started yet, because the year before was only to plan the project. And the data collection was started by me, I think. And the first thing was to go to the health center and to go to health post just to see what are the data, and then to understand what can I collect and how can I sum the results. So it's a very complete point of view of data collection. And I think it's impossible to have this complete from the beginning and the results in Italy in 6 months.
I think that you learn a method even to deal with the authorities, to organize the projects in different levels, from the doctors and nurses and staff up to the top of the individuals.
Can I just make a very brief comment about London School of Hygiene and Medicine? Because I'm also doing the master's there. I would just like to add to what Rita has said before, that I think that there are 2 good reasons to study in an international university like London School. It could be any other. I don't know about other experience except from Portugal. One, the possibility that you will have probably to publish something, to get something published in any magazine or in any journal, but also in very important journals like the MJ, like the Lancet, because some of the researchers in this university are actually people who publish all the time in these kind of journals. So if you do if you develop some work with it, if you do some research with it, your chances of getting something published are higher. Well, and also due to networking. In London, I can say for the first time I had a chance to publish a blog in BRJ blogs. So I published an opinion article that I think for me was a great achievement. And because I had some experience, because I did some work in the university. Secondly, and finally, it's the soft skills and the career skills that they provide you at the school. They teach you how to network. They have specific lectures on how to network, how to make a CV, how to answer, how to go to an interview, what to do, how to apply for, how to do an application for an international or national institution. So it's not just what you learn in terms of theory, in terms of technical skills, but also what you will learn in terms of leadership, in terms of career management and leadership. Thank you.
Thank you, Liliana, for the contribution. We have no additional time for questions, so I know that Parma wants to contribute, but we will have time at the end of the meeting. Right now, we can have our coffee break. There is a lot to talk about. Basically, what I want to say is that it would be great if we can come back for midday, because we are going to have 2 contributions from ECDC. Sabrina Bacci is going to talk about EPIET, and Alessandro Cassini is going to talk about the role and the mission of ECDC. So it would be great if we can be back by midday. So let's get a coffee and be back by then. Thank you.
No, ma non sono, perché io avevo detto glielo diciamo che li facciamo intervenire mattina. Parma, mi sentite? Ciao Parma, mi sentite?
Niente, qui ci stiamo allontanando per la pausa caffè, parlo di fatto soltanto con voi, gli altri non mi sentono. Mi volevo appunto scusare, ma siamo un'ora in ritardo, quindi ho già detto a Guido che vi faremo intervenire assolutamente come primi alla fine. Ovviamente se trovate domande anche sulla prima parte le possiamo sicuramente recuperare. Bene? Quindi mi dispiace per questo setup che stiamo trovando.
Va bene, salve.
Va bene? Ah, perfetto, ora puoi sentirmi però, non posso più parlare male. Scherzo, Gioia. Perfetto, va bene, Parma, vi congedo pure voi per 10-15 minuti per un coffee break. Mi dispiace non poterlo condividere con voi, qui abbiamo cornettini e marmellate, però immagino che anche voi avrete portato qualcosa per passare insieme la vostra pausa. A dopo. Sì, lo voglio stesso. Lo voglio stesso. Perfetto, te lo faccio. Mi devi dire come metto la mia presentazione. Sono il primo, quindi la possiamo andare a preparare subito. Se la prepariamo subito. Sì, sono il primo, vabbè. È sul drive, è sul drive, capito? Ed è questo.
Non è sul suo drive, scarica. Scarica le mie cose lì.
No, ed è scaricato, è nella penna, il problema è che nella penna quando la apro si vede male, per questo la voglio far vedere su internet, raga. Questa è la truffa.
Ha spento il monitor.
Come chiudo tutte queste cartelle?
Minuti rientro, prendi un bicchierino e rientro.
Ma come si chiudono tutte queste cartelle? Facciamo un po' di pulizia.
Vacci 2 secondi. Tirati, vacci, se no ti ci porti di forza. 5 minuti stacca.
Il discorso è che li devo contattare io questi stoccolmeni, li potete contattare.
Qua sono quelli di Stoccolma. Io l'ho già raggiunta quella che mi hai detto tu.
La devo vedere da qua. La devi far vedere da qua, ti vado a fare vedere.
Che vuol dire la devi vedere da qua?
Perché su PowerPoint, su computer mi sballo.
Vabbè, così.
Quindi la voglio far vedere dal computer e la gestisco io. E gli altri la vedono ora?
Aspetta.
Sei sicuro che gli altri stanno vedendo?
Gli altri in questo momento niente.
Intendo Parma, gliela voglio far vedere a Parma.
Per farla vedere a
Parma, streaming, chiunque sia altro.
Facciamo così.
Cioè anziché vedersi Parma la mia bella facciuzza, francamente si vede nella presentazione. Ieri ci siamo riusciti.
Condivisione, dov'è?
Parisi ero.
No, soltanto.
Sì, questo è.
Facciamo soltanto questa?
Sì.
Condividi lo schermo.
Perfetto.
Vai a vedere nell'hangout cosa si vede.
Ah, perché da lì.
Al posto di Parisi, al posto di questo si dovrebbe vedere.
Fammi vedere.
Siamo. Salvo è pronto. Salvo è pronto.
Ma Salvo non parla adesso, parla Alessandro Cassini e poi parla Sabrina Bacci. Per questo dico facciamo Stoccolma. No, siccome loro mi scrivono.
Comunque, allora poi mi
il tuo o con il mio Skype?
Uguale, anche con il
io qua sono aperto.
Con il tuo
Cesare online, Alessandro Cassini.
Allora,
chiamo Alessandro Cassini.
Un connettino.
Cosa? Vabbè. Sì.
Cazzo, fatto sì, ci volevo solamente no, ci colleghiamo.
Alessandro?
Sì, aspetta che ho un po'. Ok.
Sì, un attimo. fermare, lo metto in qui.
Eccomi.
And suboptimal vaccination of especially for certain groups of population has helped the recruitment of next slide, number 8. Just to talk a little bit about the surveillance. Before CDC was started working, there were many disease networks. They were paid through grants by the European Commission, and they were managed by a PI, principal investigator. They would have associate partners that generally would be national health institutes or universities, and they would have sort of their own tailored database that they would annually give to the European Commission. But it was a scattered situation, and there was no way you could have a broad overview of what was the impact or let's say the incidence, that's the number of cases of infectious diseases in Europe. So next slide. ECDC has been working very hard since 2005 on a big database called PESI, which is the European Surveillance System. It's a very big and important database where all member states upload directly their surveillance data, and on the other side, many member states, but not only member states, Commission, WHO, and other CDC partners can download directly their data. Now, we are also working on a big dashboard where even a normal researcher or user from anywhere in the world can download the data and also map the data, so there's an integrated GIS system with it, and also do some analyzing of the data, and you can download the data. It's a bit like you do already with that. Next one. So next to PESI, we have other one being the EWRS, which is the Yearly Warning and Response System, where member states, when they have an important outbreak, they can upload their information, and the rest of the member states or the EuroNet Commission can read it. Of course, there are people that are authorized to upload and to read the messages. But then we have also within EuroNet, we have a group working on systemic intelligence, where they scan the news and try to understand if there's going to be or there is an ongoing outbreak that hasn't been picked up by the National Health Institute yet. Next one. There's another, next one again. The third area of activity, which is scientific advice. And this stems from the founding regulation, of course, that states that the center shall provide independent scientific opinions and scientific and technical evidence. And this is a very important part of our work. Sometimes this work is done through scientific panels with experts that were called across all of the European Union. Sometimes our scientific advice is because a member state has asked us, or because we decided it was an area that needed some more work on. So, please, next one. I'll just give you 3 examples, very quick examples of what kind of scientific advice we provide. There are short questions. Next one. And these short questions come from generally from the European Parliament through DG Council, which is the Director General that works also on health. I'll just give you some examples of some questions that we've had lately. For example, according to a study published last week, 1 in 2,000 Brits could have carried the human form of mad cow disease. So what are the European statistics, and what is the long-term outlook on microbial disease? So we prepare a 1-page document on this, and these are, let's say, short scientific advice that we give. Next one. We have also longer, unplanned bigger assessments, and last year, for example, there was polio that was isolated in Suez in Israel. Of course, these cases still were detected in Israel, and so very quickly we used that to do a quick, rapid risk assessment on what was the polio threat in Europe. But after that, we prepared a bigger document, a more comprehensive document, through setting expertise in the house, but also calling in external experts. We had to review the literature, so we did a systematic review of the literature. We consulted with external experts and with WHO and other partners, and then we had to identify the consequences, because we have an annual work plan, but each time something like this happens, we then have to change a bit what we do during our normal annual work plan. And after some months, already some important conclusions were found. We need to enhance surveillance, so not only of cases, but maybe also doing some sewage isolation. Member states are not, these are very political answers as well. Member states are not recommended to treat symptomatic people, migrants, from polio infection when they come in Europe. Member states should update and test their preparedness plan, and there is some scientific evidence on the ICD against the OPV. Next slide. Another planned long-term scientific opinions that we have to give sometimes can be self-asked, sometimes can be asked by a panel of experts across the European Union, which we call the advisory forum. They, of course, are experts for next year, and there are some examples. And I'm going to talk about the last example that is listed here in the list, our estimation of the impact of infection, which is a big project that we call the Burden of Communicable Diseases in Europe project. And Guido has helped me in the past month with some parts of this project. So next slide. What we want to try to understand is what is the true impact of diseases, not only through incidence or mortality of diseases, but also through what is the impact to people that have the disease and to society and to the health system. So one thing that you need for that is to choose a common indicator, or what we call a common currency, in order to compare diseases. So you can understand how hard it is to compare what is the impact of invasive pneumococcal disease with what is the impact of measles, or what is the impact of chlamydia. So to do that, you choose a common indicator, and we chose the next one, degli. Degli are disability adjusted life years, and they are composed, just to let you know, of two main bricks. One is the mortality brick, which is the years life lost due to mortality, and the other is the morbidity brick, which includes also how disabling a certain condition is. The next one, Guido. In the graphical terms, this is what it means. You're born at 0 years old with a full quality of life, let's say. After living 20 years, there's an infection or some sort of other disability or disease that comes in and lowers the quality of life of a certain amount. And the person lives with that quality of life for another 40 years, and then dies due to the consequences of the spread of that disease prematurely at 60 years old instead of dying at the normal health expectancy, which can be more or less around 80 years old. So the pink plus the blue boxes are what we are calculating, the values. So we calculated and are going to publish. Next one, Guido. The burden of infectious diseases in Europe. On the right side, the table that you see on the right side, you will see the ranking of diseases according to how much they are notified to CDC. So the number of cases that are notified. And chlamydia by far is the disease that's the most notified in Europe to CDC. However, on the left side, we've done a huge work understanding what is the true incidence, what is the impact of the sequelae, and what is the impact of the mortality of each of the diseases, and re-rank them completely. Now, don't look exactly at the ranking, is going to change a little bit because thanks also to Guido, we've changed the model, so we will have a little bit of differences. But the point is, the ranking completely changes when you're looking at a constant health measure like we did with degli. And this will help us understand what is the true effect of diseases, what is the quality of the surveillance system that we have in Europe, but it will also help the Commission and the national member states maybe decide how to invest their money in healthcare. Next slide. Just show you an example. This is again the burden of all the infectious diseases, and the pie that you see on the bottom right side is each group of diseases, like for example the vaccine, preventable diseases, etc., how much they contribute to the overall burden of infectious diseases in Europe. But what I wanted to show you is how this ranking changes within in an outbreak situation. So we don't like what there has been a big outbreak of measles in Bulgaria in 2010, more than 22,000 cases. And I was surprised as well some weeks ago when I did this estimation. What comes out is that the outbreak of measles in Bulgaria in 2010 had a higher impact than influenza in all of Europe. So another interesting part of this tool is that it can very quickly really such a big outbreak. Next one. So now, just briefly, I'll end up my talk showing you a little bit what to do also with communication. Next one. We create a lot of technical reports, mission reports, special reports, rapid risk assessment, etc., where we try to answer the questions that I showed you earlier. So we have a team of editors that then will edit all of these documents and publish them on our website. Next one. We also have an interesting multimedia where there are nice little movies on not only on what we do here, but also, for example, on the news outbreak and the increasing numbers of NDR that we are observing across Europe. Next one. There's very important antibiotic awareness day that is organized every year, and that has resonance in all member states. And I think this is very important, and also thanks to the efforts done here, but of course not only. Antimicrobial consumption has decreased, and hopefully we will see some trends in the antimicrobial resistance decreasing as well in the next year. Next one. We also organize a conference every year, and well, now Cultural Abstract is closed, called Carda, but we very much welcome abstracts from all over the world, especially I'm a medical doctor, former resident in public health like most of you, and I think it's important that we try to communicate our projects. And this is a very interesting and nice platform, especially if you want to present something on communicable diseases. Next one. There's also a traineeship program that organizes every year. It's for, you can decide if you want to stay 3 up to 9 months, and you'll have a tutor that will help you identify your objectives and also manage your things. And the last one is yes, next one. And so thank you very much. This is the staff. As you can see, we're not a very big agency, but I think we can manage to do quite a lot with only about 300 people. So thank you very much.
Thank you, Alessandro, for your presentation. Since we're running out of time, I would postpone the questions about your intervention, and I would move quickly to Caterina Mammina, another medical doctor, an Italian one that is working at ECDC as well. She's a former public health resident, and she's going to talk about EuroNet, that is a program on epidemiology, but she's going to give us all the details about it. Please, Sabrina.
Hi. Good morning, everybody, and good morning, Palermo, Parma, and our colleagues in France and the other ones who are connected. And thank you very much, Guido, for the opportunity to be here and talk about my experience during the EuroNet program. I have to say that I am, after the EuroNet now, I am working at the CDC here together with Alessandro, and I am working in what you mentioned before, the surveillance and response unit, and I take care of surveillance of vaccine preventable diseases. So my everyday job is now to be in contact with the member states and make sure that the data right, the data is interpreted correctly, and keep that information to our stakeholders regarding the vaccine preventable diseases. So we go to the first slide. Next year. So EuroNet, it is called the European Cancer Intervention epidemiology. It's a 2-year program which started in 1996, and it is currently funded by ECDC and is managed by the Communication and Training Unit here at ECDC. The aim of the program is to strengthen the surveillance of communicable diseases, to build a network of epidemiologists across Europe, because the various people who are selected come from different European countries. So the idea is to get together and to know each other when possibilities of collaboration will arise in the future. And then, of course, to train these people in their technical capacity, so to increase their knowledge in surveillance, in outbreak investigation, but also in applied research. Next one. Currently, there are 2 pathways for this program. One pathway has a main focus in epidemiology, and this is the one I did 5 years ago, which is called Elche. Then there is another path which is called Diploma, in which the people who are doing this are mostly trainees with experience in microbiology, who want to have a public health approach. This is quite a new pathway, was created 3 or 4 years ago, but it has been already successful, because the idea is that we want to train people in epidemiology with a vision on public health, but also with the idea that they should collaborate more and more with microbiology. And the same, microbiology who should collaborate more and more with epidemiology. For every structure, there are 2 possibilities: to be in a country different than your country of origin, defined as the country of your passport, and the other possibility to be trained in the same country where you come from. The one I did was the first. I was placed in another country, and it was the only possibility at the time I did it in 2007. The next one. The objectives of those 2 years, they are quite wide. So, and for each objective, the idea is that there should be some concrete document, some concrete report of what has been done. And the idea is also that for these objectives, the fellow should be the main investigator, the main actor in the different projects. So the first is to lead at least one outbreak investigation. So this also means to write a report, to lead actions, write a questionnaire. Then the second objective is to basically build a surveillance system, which is not in place, or evaluate an existing surveillance system. The third objective is to develop research projects and conduct this type of study on a specific public health issue. Then it's more general objective to become familiar with laboratory techniques which are relevant to public health. And here again we see the connection with the microbiology part. And then also communication objectives, to present the findings to one of your projects to the scientific community. One time at least in an international conference, and then one time at least with a submission to an international journal of the publication. And then the last objective is to teach epidemiology to a full audience. So it can be nurses or other higher educated people. Next one. The training format of those 2 years is a mix of theoretical training and practical work. The theoretical training is made up of 3 weeks introductory course, which wants to have a basic or common understanding of epidemiology among the fellows, and then 7 weeks of modules, so-called courses, on different topics. For example, how to use computers during outbreak investigation, so module on vaccinology, for example, or also a module on communication. So this 7 weeks become a different. Palmira claims that the Australia is mostly spent in the National Public Health Institute, which can be often national, but at times can be a regional institute, and due to the different projects, and the supervision is done by the people in the institute and also by the census coordinators. Some of them are in SCDC, EuroNet, and others are in international institutes across Europe. So the supervision is done by email and also when we meet during this course. The next one. There are different training sites across Europe. The list is the one you see now is not final because every year about 10 12 locations are chosen, and not every year all the locations are available. And so this list also can change in the next year. But the idea is that more and more European countries should be represented over the next years. And it has increased quite a lot, I think, during the years, with Eastern Europe being more represented than in the past. The next one. So I'll now have time to go to the selection procedure, which maybe some of you could be interested in. Here is the link. And just to say, of course, many of us are also interested in very popular locations like London or Paris. I actually ended up in Copenhagen in Denmark, which I think, even though it was not a popular location because it's different, of course, from bigger cities, but still it was a very good experience. And then I just, next one, discussing some of the projects on next one, so just some of the projects that I did during those months. And when I got there, as you, I was a resident in a public health at the time of application, and then part of the residency, I was working in Italy at the Universitario di Sanità in the Department of Epidemiology and Surveillance, in the section of Epidemiology and Surveillance of Infectious Diseases. And actually, that was the department which was hosting the foreign Elche fellow at the time I was working there as an Italian secretary. And just in general, I was very interested in international exchange programs like Erasmus, IMC, Flagship, which I did, and some other hospital training in the United States that I organized. So that is also something that we look for in the selection criteria. Next one. So the experience was back actually more than 5 years ago now. I was based in the National Public Health Institute, which in Copenhagen is called the Southern Serum Institute, in the Department of Infectious Disease Epidemiology. This is a small department of about 30 people, and the working language is Danish. So this means that the meetings were in Danish, except where one international staff was present, and then the meetings were in English. But this also meant that the computers were in Danish and software in Danish as well, which was quite something I didn't expect. So it was something quite big for me. The next one. The activities of the department where I was trained, the business activity is actually to take care of the surveillance of all notifiable diseases in the country. The department is also responsible for the national vaccination program. As a part of this task, they also give advice to medical who have questions about vaccination. General practitioners, this part about the questions is mostly that in Danish, so it is not for the international personnel. The department will also take care of educational healthcare staff, so also residents in public health, and also other projects in connection with the university. They do research in connection with questions that arise during the normal surveillance of infectious diseases. They take part in international projects. For example, the project that Alessandro was mentioning before, the project on Borderline Disease, Denmark was participating with this department. also international health regulation network. And also, the department is also conducting bigger projects. Two big projects which happened at the time I was there and were recently completed is to develop a registry of national registry of vaccination and also national registry with all microbiology parts of the country in one single place. The next one. Just another of my projects. Of course, the projects are a result of what happens when the fellow is there during those months. So it can be lucky and get projects that you actually very interested in, or the opposite. But overall, in 2 years in general, you get a good variation on our activities. So one of my main activities was to investigate, as the main investigator, the hospital outbreak of Rocío in Sicily. And it was the first time that actually some help from the hospital were directly requested to the Paris permitted. So it was a first example of collaboration in this field, and this was very rewarding. And I think it was also interesting for me because as being the main investigator, I had to write a protocol, develop a questionnaire, collect the data from the medical records of the hospital, do the analysis, do the report, and actually also communicate the findings to the Ministry of Health because there was quite a lot of attention to the topic in media, and also write a publication, okay, but also I think it was important because there were some changes in the legislation after this outbreak, in how the hospitals were screening which products they were using. And then there was another smaller activity which did data analysis and questionnaire creation to other outbreaks of food-borne diseases, norovirus and salmonella. And these were actually coming before the hospital outbreak, so because of the possibility. Can you hear me? Okay. To get familiar with the topic. And then the next one, the research study. I was also able to be the main investigator of a study of flu fever in Denmark. Actually, this was a very simple study. It was just creating a protocol, developing a questionnaire, and collecting data, analyzing data, writing a report and a publication. But the study was very simple. It was just proportion and a chi-square test. So it was nothing complicated. But we had to do the study to understand if flu fever was present in Denmark. It was also a request from the ministry, and also to decide if flu fever had to be become a reportable disease in Denmark. So actually, just a comment at the moment, I wasn't so excited about this study, but I also think it was actually very important to the department to take policy decisions. I was also the main author of another registry study, which followed the outbreak investigation on Clostridium difficile and mortality associated with different leukocytes. And so that was also something very deep, which actually in a very specific field was very much appreciated. And then second order in another small study on flu fever also. The next one on surveillance. During the 2 years, I was running the routine surveillance for crucial double diseases. Not many cases, of course, but also a good opportunity to see all the flow surveillance, from case notifications, clarifications with the doctors, and then justifying the cases. And also, actually, in Denmark, they have an annual committee, so coordinating this committee on crucial double diseases. Then also there was another project to evaluate the surveillance system of chronic B hepatitis. However, this project was not concluded due to different reasons, independent of my will. And however, the objective of surveillance that you have to reach by the those 3 years was also reached because of the routine surveillance I was doing and the protocol, which was enough to actually succeed in objective. The next one. The teaching was some teaching on outbreak investigation in epidemiology course in Sweden, and some teaching to the nurse at the Southern Palermo Institute, and then some other smaller support to master students. Next one. Regarding the communication, I was able to present both years at the study meeting. This meeting organized by degli, which I also invite you to submit your project to, because it's a very good window to understand what is happening in Europe on surveillance, on infectious disease, and also it's a very good opportunity because of specific focus is given to people in training. So both projects on Preventive and President Fisher were presented. Also, next one, other communication activities. Small towns with the names go fast. So I was also invited to some related conferences. The invitations were always received. And other international publications. Also, the next one, not compulsory, but I was able to have an international mission, that's how they call it. It was still in Copenhagen, but at the international, at the WHO Regional Office for Europe, where I assisted the response team during the pandemic with data analysis, data collection, and other response activities. So that was also an excellent opportunity to have. What happened to my life after Elche? It was 2 years of Elche in Denmark. Then I stayed on 2 years, actually, in the same institute and department, working on a ECDC funded project, so working again always in English. The project was called EuroNet. Then I moved here to ECDC to help ECDC to in the surveillance of next one. Just some comments. I think it was an excellent experience. The objectives are quite a lot, and it is not possible from the training perspective to have all of them met as a main author, and actually the coordinator, the conference is aware of this. So it's not possible to do all of it. Was the opportunity
e basta, basta mica tanto. Poi dobbiamo studiare, abbiamo gli esami ogni anno, la finale, il tirocinio, Niente, no.
Immagino.
Ho già fatto un master sempre in Caterina Mammina e un altro scuola triennale a Bologna. Però
time, and also from the customer perspective, when you have to look for housing, for the design, Google Translate was not available. So that was like a big it's difficult to go back. Those have been two very exciting years, and many of us remain at home. And also, it is a time-intense period because the benefits are quite a lot. The next one? Yes, that's it. Thank you very much. And I think Alessandro will give you some familiarity to the work to do discussion or something. Thank you.
Thank you, Sabrina. It was really interesting. I think that it's not easy to get to know a personal experience about EdIT. You can read a lot about it online, but I think it is really interesting to hear something about it from former public health president.
Thank you.
So I would open the floor and I would ask if there is any question. If not, I would just say thanks again to Sabrina and Alessandro because they've been really kind to be part of this conference. They work really hard at ECDC, but they have found time to present their work, and we're really grateful for them. So thanks again, and I would like to introduce Cesar Velasco Munoz. He should be there with them, but although it's ECDC, he's going to talk about another organization, because he has been to the WHO, the headquarters in Geneva, and I would ask him to introduce himself, and I will just change his slides while he's talking. Just say next one for me to understand. Thanks for being here.
Hi, good morning to everyone. I don't know if the slides are on the screen, but I will. Okay. So I'm Stefano Velasco. I come from Spain. Of doing an internship in WHO for 2 months and a half, more or less. The first slide, if you can, there is a photo of me over there, just for you to know who I am. So WHO headquarters are based in Geneva, in Switzerland, pretty close to your country. And this is the badge that we are going to provide you for an internship in WHO headquarters. The very nice city and with nice country, so I think the atmosphere for making an internship over there with a non-official activity is pretty nice. It's something that you should consider. So next slide. WHO Geneva headquarters are organized in different departments. Something really important that you have to know. All this information is in the website. The different departments that are offering internships or volunteerships in WHO Geneva are represented in this slide. Family, women's and children's health, human management, health security, health system and innovation, HIV/AIDS, with all other communicable disease. Then non-communicable disease department with tobacco control inside of it, and polio and emergency. So these are the different opportunities for interns. You may discover that there are interns from many different backgrounds and very different perspectives and levels in WHO. they work in, you get to know how the headquarters act and interact within the regional offices and with the national focal point for WHO, which is pretty interesting. And in the next slide, I'm going to tell you which is like we have a very interesting topic on how to apply to the internship. We have the main important things that you may know before applying. So during my internship, I was doing several things, and most of it was supporting my department. I didn't do any field work, which is kind of important to know, because it's difficult to do field work in WHO as an intern or as a volunteer. And nevertheless, you have the opportunity to publish in peer-reviewed journals if you have time and you are like encouraging your department to promote publications, because what they will expect from you is just technical advice and collaboration. Next slide. So for the internship, there is an official internship application. This is a screenshot for the WHO website. They explain perfectly what you have to do to apply. There are some timelines that you have to respect if you want to apply for the Consulta internship. You can either apply for headquarters or for regional offices, and you can do it twice per year officially. Sometimes there are like several other applications for internships, but it doesn't. I mean, you cannot predict that. You have to be like really looking into the website just in case you have something extra. So about the internship. Next slide. The application that I show you, that screenshot, is the application. But there is not doing an official internship. In the end, it's the same. Your legal conditions are going to be the same, your badge is going to be the same, but the way of getting the internship is completely different. Both ways, you have to complete all the information and the application form online. But with the official one, supposedly you have to wait for the official procedure to be completed and for them to contact you and interview you. The problem is that there's going to be people contacting directly departments in WHO headquarters or regional offices and official placement before getting officially selected. And this is how it goes with 80% of the people doing internships in WHO. So what you may know, that unofficial internships are the same, that you contact the department within this period, so you apply for the official internship, but you later run contact with some WHO staff, and you try to be selected out of the list of applicant candidates. The WHO curriculum online is mandatory, either to do the official application or to the unofficial. So if you may contact tomorrow some staff in WHO to run internship with them, they will ask to complete a WHO curriculum online. Otherwise, they won't be selected. Then there are two different positions, intern versus volunteer. I'm talking about internships because everyone is going to talk about internships, and because the fact that you will be going to be intern batch. But officially, as you're graduating student, you will be volunteers in WHO, which may like impact your curriculum in a different way. Supposedly, that graduated students, and you may have more responsibility in the department as volunteers, even if you're called an intern. Officially, you're volunteering. So my recommendation, go there for a 2 to 3 month period, not less, not more. They will probably suggest you to be there 6 months. I don't think, I mean, depending on the department, it's either positive or you will be like losing a little bit your residency area. You will be repeating tasks or being just doing the same during a long period. Most of the things that you're going to learn are classification procedures, and you will learn that in 2 to 3 months if you're fast. Maybe depending on the department, it could be interesting if you're involved in a really big project to be there for longer time. So I suggest you to be during the spring period because there is a worker assembly in May, and if you are there, you can participate as an observer or sometimes with your country delegation. This And then the recommendation is practicing out of the box. Selected partner in WHO with a topic that is not really familiar for you because they are not really experts, they're not really demanding with your background, and this is the way that you can kind of have a different view on something that you're not really an expert. This is a good opportunity to do that if you want. So next slide. There was a frequently asked questions section in the website. They explain you a lot of things. I think it's important for you to know that you won't get financial support from WHO headquarters office, either in regional offices, either in agencies for WHO. You will never receive any allowance in the United Nations. So that's something important for you to know. Next slide. Here comes the practical stage. So the accommodation in Geneva is pretty expensive. You will have to pay like in pricing between 700 and 1,100 euros per month to have a single room, which would make you think about going or not to Geneva. It's expensive. The food is expensive from the supermarket, but you can have lunch menu for 7 euros per day in WHO building. And the transport would be around 50 euros per month for the Geneva pass to move around the city pretty nice. So some useful contacts. If you decide to do an internship over there, I strongly suggest you to join both Geneva Association and Geneva Carda Solutions Facebook group, because there you may find information about housing, information about how you can deal with the internship the first day, and it's going to be really, really interesting for you to join the Facebook and get information from them, better than just going to Facebook or Google or whatever. And then the next and last slide, overview. So doing an internship in WHO gives you an international public health framework, which is kind of nice. Then technical versus international health policy. I strongly suggest you to do a WHO internship if you're looking for the international health policy framework. If you're looking for technical training, I rather go to other things. So it's a really good way to combine. If you have been or you're gonna be in a different technical content, but it's gonna be more about international policies and about technical issues. Depending on the department, but this is like the general overview. Then field work versus office work. As you may know, WHO works in headquarters, mainly office work, and this is something that you also have to know, not to be disappointed later on. And the international working environment is pretty nice. It's going to be multidisciplinary. You're going to meet people working in several areas from different parts of the world. There are a lot of seminars and day courses, which may encourage you to do an internship over there, because you have lunch seminars, many topics, everything, instance meet with the experts, so very useful, and meetings with committees and meetings with your department may also give you a lot of background on your topic and in other topics at the same time. They really encourage the training, the internships, the training, to go to these lunch seminars and the different training models that you're going to be offered. Yes, there was a mission and vision that you will quietly acquire during the internship, and you will leave WHO with a really good overview about how it works and which is the mission and the objectives of WHO worldwide. And that's everything. This is my contact in the last slide. If you want to contact me in the next year, if you have any question, whatever, I will be more than welcome. I mean, any question will be more than welcome. That was everything. Thank you very much.
Muchas gracias, Cesar. You've been really straightforward. I think it's really interesting to understand
how does it feel to be an intern at WHO? I think that everyone here can have this opportunity, and I think it's really interesting for us to know a little bit better about it. I know that Cesar has to leave, so I was wondering if there is any question that we could address right now. If not, I would say bye to Cesar, that I know has to go to the airport, and I would ask to Salvo Parisi to tell us about another experience at the same institution, but in a different city. So WHO, Euro, in Copenhagen. Thanks again, Cesar.
Bye, take care.
Well, okay, so we'll ask you to follow my discussion, my speech, just for 10 minutes. Hopefully I could skip it to be faster to you, because I guess you are almost started. So, well, let me introduce once more. I'm Salvo Parisi, medical resident at the School of Hygiene and Preventive Medicine in Palermo, and I decided to do an international health electives, as we call it in our European network of medical residents in public health, at the European office of WHO. Basically, let me tell you before that WHO is part of the UN, of the United Nations system, and is recognized as a specialized agencies. If you see, there are many, really plenty of agencies among the UN system, and WHO is one that covers the health topic. And WHO itself is organized in regions that, if you look and pay attention to the colors, it doesn't match with the political borders. For example, the regional office for Europe, it includes also Russia and even the countries in Central Asia. And Africa, for example, for any other political reasons, for example, is divided into the Afro region, and some countries such as Morocco, Libya, Egypt, and Sudan are part of Afro, and the last one are part of HEMRO, the East Mediterranean Regional Office. And all the 6 offices of the regions, so also WIPRO, SEARO, and HAMRO or PAVO, and are, let's say, supervised by an headquarters that is based in Geneva, and they include inside, within the organization, at least they follow the departments or divisions that are the most, those that are most commonly present, such as non-communicable disease, communicable disease, that also includes health security and health environment. And other main important divisions are the policy, governance, and information, evidence, and research and innovation. So, well, within the European region, I already have told you that we have basically 2 main offices, the headquarters and then the one that is based in Copenhagen as regional. But among the countries, there are 2 sub-regional offices that can work in a specific topic, like the one that we have in Italy, in Venice, that is for migrant health, and and one more in Barcelona that is for health system and health economics mostly. And then the other circles that you can see in the map are basically the country offices. Well, my experience was in the Department of Communicable Disease and Health Security and Environment. It's in a very modern and beautiful building that I will show you after the end of my presentation. The building is a shape of a star and is so divided in pillars or wings. And WHO is based in the second floor, and the divisions are divided among the pillars. So the division of communicable disease is in the 2.4, that means second floor, and 4th figure floor, where we have the only one program that is with restricted access. So you have to always to show your page to enter. If you see even in the indication there, in the indication the door. And after 6 p.m., that is very likely, very usually happen during the week. You have even you can also have to type a password to go inside the office. And well, it already happened to myself. It already happened to me that experience. I was not forgetting the password, but the touchpad was not working because of my password includes a number that there doesn't work. And what I can say is that that bill includes, let me remind you, one more different agencies. One is also UNOPS, where there are different people that come from a background in the army. And I experienced with them even another way to go inside a department, even if it's with restricted access. So it's just taking the safety floors, and I was inside the department, even if I should say that maybe in the streaming line. Anyway, so the program where I'm currently intern is called ARO, Alert and Response Operation, that is also a part of a global program that is called GAR, or depending if it includes also other services and other network, GOR, Global Outbreak Alert and Response Network. And what we do is basically make a surveillance among all the events that can be caused by different hazards. So the definition of the department say that it's a communicable disease, so maybe you can think about something infective, but it's not only. We cover all the possible hazards, such as also, and we are under the IHR regulation, the International Health Regulation, so the events are, can be caused by different and several hazards. Just let me list them. The more important are not only biological hazards, such as also, as I already said, infectious disease, but can be also chemicals, radionuclears, and natural disaster. And one occurred even, or one also occurred just before I was leaving, flood in the Balkans. And so we also follow and try to help from the regional office even during a natural disaster, and I will show you after how. In this page, you can even see one of our main important operation and task. And this is what we do and how we also appearing to the public, because a lot of information are restricted or are confidential only for WHO staff or interns. But when we go into the public, it's mostly with a DON, disease outbreak news. So this screenshot was done just yesterday. So you see that the last DONs that you have in the right side of the screen is one about MERS coronavirus. If you ever heard it, it's a new virus that was for the first time detected and isolated in 2012, February 2012, and actually the epidemiological investigation is still ongoing. We still don't know a lot, and there is currently an emergency committee that usually meets, has already met several times, and the last was on the 17th of June to assess the risk of spread of MERS coronavirus, especially in the upcoming weeks, because there is going to be the Jadi and the Ramadan. The Ramadan actually starts tomorrow. So it's a mass gathering, and it is another kind of event that we follow even before that something happened. So usually we follow any kind of mass gathering we start planning in advance, and with the collaboration of all the region involved, headquarters almost always, and even with ECDC, that in this case has mostly the role to elaborate a rapid risk assessment. So, well, maybe I already have said enough about the global alert that was even in this other slide, but what basically does an intern at the alert and response operation program? Well, we have basically two different and parallel tasks. One that is daily, and one a daily routine list of tasks that is make surveillance of the event, and one is start preparing and preparing the response when any kind of event is already started, is already happening, and we have to start with the response. So, but saying what I do when I arrive at 9, I arrive at 9 kind of Italian time, because hopefully my department is not Italian, sorry, Latin. Hopefully my department, luckily my department is composed by a Brazilian lady that is my supervisor, and so you can understand how she is proud right now about Brazil World Cup and even about the timings. And and then because we have a daily meeting that is at 9:30, and so in this 30 minutes we check our Outlook, and what we do is checking our Outlook in our email if you have received any notification by the national focal point IHR that are in each countries. If they have sent some notification about any events that they have to notify because of the international alert regulations, or also we are also have done a subscriptions in many servers. One was maybe named before by my professor, Mammina Promet, that is a server that has basically two main points, one in Russia and one in US. It's just screen plenty of media article health related per second. So we have done a subscription in Promet, selecting all the health topics that we could be interested, and once that we receive, we just read and forward if it's interesting news, or we discard if it's not. Well, how we do it? It's this screening. It's so well, as already say, the daily routine is making a filter in the first yellow base, so the daily event review meeting. Once we met every day, and well, I haven't said that it's a 9:30 because we also invite several members of other divisions. So it's I would say that it's a time of the day when they have already have done and are free of the meeting, and we filter the noise and the signals, how is illustrated in this environment, and we detect what is an event. We have, of course, an instrumental decision to understand and to assess what is an event, and but if you are not sure, we can ask for a verification. So let's imagine that, for example, I get an email that is a prompt about a large number of cases of measles in Sicily or in Portugal or somewhere. Measles is not an unexpected disease, is not unusual at all, especially in the countries that I have listed. But if I want just to be sure that the number is not unusual, is not higher than normal, I can ask for a verification to the national focal point that could provide me the last report, or even by myself I can see and look in our here report for any related for any topic, so even for any pathologies. So I was saying that first to ask for a verification, the disease, or well, I say that could be even a radionuclear, or could be a chemical, or a natural hazard. So if it is unknown, not only disease, but also an unknown natural event, or an unknown disease, or if it is a potential for spread beyond the national borders. Actually, this is the first red light that we always care about. Once there is the risk for national spread, usually it's already enough, or quite enough, to ask for a verification to the national focal point. And then the other instrumental decision that is almost the Bible for an intern or for whoever works there is the Annex 2 of the IHR, of the International Health Regulation. And the Annex 2 basically helps you to decide if you need, if a national focal point, or even a doctor that works in an hospital or in a primary care facility has to notify or not. So when something has to be notified, has to be notified if the public health impact of the event could be serious, and you have a risk matrix to decide it. I'm not sure if you ever use risk matrix, but basically it's done. It's just describe how an event could be likely to happen, and which can be the consequence. So, for example, only one event of polio should be notified because it's of a serious health risk, and even the impact for the public could be very high. But the same could be, there are also listed of specific disease that are HIV, for example, and smallpox. And proceeding with other possibilities if the event is unusual or unexpected. So here sounds more like not only an outbreak but even a natural disaster. And if there is the significant risk of international spread, and unfortunately in these modern times of traveling because of tourism reasons, of friends and relatives or business, it's something that is very common to have. And then if there could be a risk for the trade, and so if we should already start thinking about some trade restrictions. So our work is basically trying to just to reduce the timing of verification, detection first, then verification and assessment. So, So I want to share with you what happened during my internship, so which were the main important events, except, as I told you already, the daily routine that was checking my mail and looking if the number of hepatitis A or the number of measles were higher or lower, and something that we can't say no to be involved is when an emergency happens. In this case, all the staff is involved in that topic. So when I was arrived, the first topic that I found was the Ebola outbreak that is still ongoing in Western Africa. Actually, WHO has sent already a mission last May, but now, and we were supposing to have stopping already the chain of transmission, but now the number of cases is already increasing, and even one more country, Liberia, is involved. So what we are thinking is to, even if here I haven't written which would be the decision that we should take, because I say to invite you to look at the next EuroNet newsletter issue, where we just submitted an article about Ebola. But just to give you some information about that, we should strengthen again the control measures of infection control, especially in the hospitals, because as often happens, not only for Ebola, but even for other infectious disease, the hospital is the most dangerous place, and not only for the patients, even for doctors. In MERS, that is the next topic, and but even in Ebola, doctors, the number of cases of doctors was almost an half of the global numbers. Sorry, not only doctors, but all the healthcare workers. Why? Because sometimes we just forget to follow the standard measures, the standard procedures. We consider standard something that we have to do when there is an emergency. Standard means every day, every time, everywhere. So, and well, I skipped before polio. About polio, in the last emergency committee, we decided something. The strongest decision that WHO can take about an emergency. Polio was declared last May as a public health emergency of international concern. This means to mobilize. It's not just an acronym or a name. This means mobilize human resource, means mobilize even budget, even money that can come from the donors or even inside within the agencies. Once that you declare that it is a fake or fake, because we are still thinking about which sounds better. It should be called fake or fake. Maybe you can give us a suggestion after. You know, fake sounds like maybe unpolite, and fake, it's something that is maybe doesn't match at all with a so large emergency. Seems something not real. So, well, I have already talked enough about MERS coronavirus, and MERS coronavirus is also ongoing an emergency committee, but the last declaration was that MERS-CoV has not yet met the criteria to be declared as a fake. And before leaving the most important topic and task where I was involved was a natural disaster that occurred last 15th of May, and it was a flood in the Balkans. This is a public report. So basically, when there is a natural disaster, first we have to assess the grade of the disaster, and it was graded as a 2, that is in 3 levels, and I can tell you that 2 is already, it means that there were involved different and several countries, and here, if you see, was involved Bosnia, Croatia, and Serbia. There were many deaths and many affected people. If you see 60 deaths and 2 million of affected people, and the health facilities were damaged or even destroyed. Well, why we follow a natural disaster? Because in this case, it's not just a humanitarian crisis, but it's also the health system that collapsed. I said already, healthcare facilities, primary care were mostly destroyed by the flood. So you have to build from zero new hospital camp or even shelters where host the affected people. And the response as an intern that has to be based in Copenhagen has to prepare a report. But during this time I was one of the few that was still on the department, because all of them were deployed among the 3 countries to help them during the crisis, depending of course of their skills, of their expertise. Some were deployed for vaccination preventable diseases that during the flood are one of the most emerging issues, or even for writing what is called a PDNA, a post-disaster need assessment, that is essential to ask them for funds in donations. If you don't write, and this is for mostly everything, if you are not able to write a good project, a good plan, it's very unlikely that you will have access to any financial support. That's why WHO support even the countries to help in even just writing a paper. And then to assess what are and identify what are the priorities. So enhance, for example, the disease surveillance, and do early warning surveillance. And then we discovered that Serbia doesn't have an early warning systems. So once that we have started, for example, for Serbia, we don't have data to make an analysis if they are more or less than before. And one of the other more important topics that was assessed during identified during the flood was the vector-borne disease, because of course it never rains enough, as we say. It rains also always in the same place actually. So after they had a flood, they had 30 degrees of temperatures, and is in a part of Europe that is also endemic for vector-borne disease, especially for West Nile fever. And that's why we started since then organizing a program of spraying, just spraying larvicide and insecticides to prevent a possible spread of vector-borne disease. So I said already that we follow also the mass gathering event, and especially for MERS, even if it's not in our region, colleagues in Copenhagen are following right now the Ramadan with the help, of course, and with the work, of course, of the colleague of Hemro. The last event that was still ongoing when I was arrived was the Olympics in Sochi, that actually because of political issues was kind of very quiet and so even safe mass gathering event, but maybe only because it was boycotted. So, and if you remember, Russia was not in a very good position during the time because of the Ukrainian crisis. So, Cesar has already spoken enough about the employment and about the internship program. Maybe you can even recognize the same screenshot. But I want to, before leaving you, just to let you the opportunity to look the UN City building that was named in 2030 as best office in the world. This is one of the terraces where we usually have lunch. Even if it's a sunny day, you can see how we are covered with very heavy warm clothes. And then, I don't know if somebody of you recognize these posters, but the UN City building is the building that hosts all the regional, all the European agencies. So it includes also UN for Europe, it includes UNOPS, UNICEF Denmark, WHO also, and this is a project made it is currently still ongoing by the UN, and this is the Millennium Development Goals, and are basically the most important goals that UN would like to reach by 2015. Before leaving, just one last thing. Sometimes we do very, this is just even to break some ice before leaving. Sometimes we do very long and intensive teleconference. So what my colleagues they have suggested to me is to make a bingo. Just to pay attention to don't lose any words during the discussion. You can even follow, as to sometimes ask it to follow hours, 5 hours of emergency committee teleconference, so you will really be very tired. And we basically do a bingo with the most common words that sometimes are used even too much, then lose their real meaning. One of those, for example, is capacity building. That is so often used, and maybe we say that they say that when they don't have anything more to say. So once that you get 5, you have just to yell bingo. Just this, just to show that you were very attentive during the teleconference. Then another activities that is done at the regional office for the UN city is the Friday bar. That is a very common in north of Europe. Is just a cocktail that we do every Friday, where we meet all the other agencies also, but even from a young point of view, you can meet even your supervisor for a beer, your director. Actually, sometimes it's also joined by the RD, the regional director, by Susanna Jordan. And well, so this is about the UN. Then I just supposed to show you some issues of the beautiful city, of the beautiful capital of Denmark. I remember when I arrived there, we call it in my mind a movie by Roberto Benigni, that once he arrives in Palermo, he said, "Il problema di Palermo è il traffico." Well, even in Denmark, the problem is really the traffic, but it's kind of different. It's not the same, as you can say. It could be very dangerous sometimes biking there because of so many, and so even they drive in pretty fast. And not only the traffic, but even to find a place where leave your bike. Thank you for your attention.
So, dear colleagues, I already introduced myself. I'm Guido Maringhini. I'm a 5th-year resident at the School of Hygiene and Preventive Medicine here in Palermo. I'm going to talk about the traineeship at the European Center for Disease Prevention and Control. Basically, Alessandro Cassini has already talked about ECDC, so I'm going to try to make it really short. I know that we're all hungry. Okay, for those of you who didn't pay attention when Alessandro was speaking, ECDC is based in Stockholm. The first picture is the building itself, and Stockholm is on the second picture. So what are the objectives of the traineeship at ECDC? Basically, it's a way to understand the role of ECDC, who has a coordination role, and you will acquire some practical experience on a daily basis work, and you will contribute to professional development by working there. On the picture you have Johan Giesecke, who is the chief scientist of ECDC while he's presenting to an Italian delegation. Some of you can recognize Professor Signorelli from Parma in the picture. So, who's eligible to do a traineeship at ECDC? Most of the cases are people who come from EU, but there are some limited number of people who come from non-member states. You need to have a university degree and have really good knowledge of English. If you are able to speak other languages, that's an asset. You don't have to, you didn't have to attend any other European institution, agency, or body before, otherwise you wouldn't be eligible. So, how does it work in order to get a traineeship there? Basically, you just have to follow what the website says. They have an annual call, and what you have to do is just that you have to send your curriculum vitae and a cover letter where you specify what kind of unit is among your preferences and when you would like to be there and the reasons that are pushing you to be there. So the selection process is basically evaluated by a phone call. So you need to understand that sometimes it's not easy to just answer to certain questions when you're not even able to see the people you're talking with. So you need to be really aware of this selection process. Then you will receive an email if you've been selected. And people who didn't, they can reapply, and there's going to be a reserve list. So the duration is between 3 and 9 months, and a supervisor is chosen to be the mentor. As for the duties, we're talking about 40 hours working week. You need to contact your supervisor most of the time in order to take active decisions. You need to have you need to be completely discreet. You don't need to have a conflict of interest, and at the end of the traineeship, you have to submit a report. But you also have rights, and as we were listening before, at the internship at the WHO, you are basically a volunteer. At least here at ECDC, you receive a monthly grant. You can also have a travel allowance that depends on where you're coming from. So coming from Sicily, it was quite good to, to fly to Stockholm. And you are going to get 2 leave days per month, and you must at least spend half an hour to go to lunch. So now it's the practical part. I'm going to talk about my traineeship and not just any traineeship in general. So here you can see my office. You can see the people I was working for, and as you can notice, I was working from the 1st of June till the 30th of November with the TB program, and Marieke van der Vet was my advisor. OCS stands for Office of the Chief Scientist, where I was based. So these are the objectives of my traineeship. Basically, I mostly dealt with latent TB, so LTBI stands for that. And I was lucky to be there when they were having this expert meeting in September. I was also in contact with some Norwegian scientists who were doing surveillance on latent TB, but I was also involved in another issue, and it's the publication of a guidance document about investigation and control of TB incidents and outbreaks affecting children in congregate settings. I was also involved in all the activities that were put in place in order to celebrate properly the World TB Day that was about MDR-TB. So what were my activities? Basically data collection, data analysis. I was collecting and summarizing information, reporting, and I was coordinating and engaging myself with all the different stakeholders. It might sound easy, but believe me, in Europe, we have so many different countries that it's always a bit challenging to basically facilitate all this process. I just wanted to show you some, you know, a bit of my daily life. As I was saying, one of the biggest projects I was involved with was the assessment of introducing programmatic latent TB control in EU. And this is the meeting itself. Another objective was the ECDC guidance, and as you can see, this is the cover that, of this publication that was published in December. Although I was not a trainee in the TB disease program anymore by the TB Day, I was involved in many publications, mostly infographics. This is how we call the picture on the right. And this is just to say that the burden of MDR-TB was the topic for this year. You can read how much it affects Europe, but I'm not going to go into that. What I just want to say is that by working with the burden of MDR-TB, I ended up working on the burden of communicable diseases. So this is the second phase of my traineeship at ECDC. I didn't plan to stay there for a bit longer, but then Alessandro Cassini convinced me to experience Swedish winter, and I'm here to say that I'm a survivor. So basically, some more months, and you've heard a lot about the project itself. I just wanted to say what another supervisor always says about this project. That good data provides, can provide good decision making, and this is basically the aim of the project. I was working with 32 different communicable diseases, so it was quite challenging to talk about completely different diseases in different days. But I was really excited about it because I could work with completely different experts who knew a lot about infectious diseases. And my work was basically to summarize all the possible evidences and to create something that we have called outcome tree. So basically, this is the natural history of an infectious disease. I chose croup fever here in order to show you just an example of what I was doing. You know that an infection can be asymptomatic or symptomatic, and a symptomatic infection can be mild, severe, and it can move to sequelae. So basically, I was calculating all the different parameters, and I was talking with all the different ECDC experts about the availability of data and the fact that we could rely on them. I did that for 32 diseases, so it's not just about croup fever. I mean, they get even more and more complicated by the time you move to certain diseases. I'm not going to show you all the tables that are included in this outcome tree, but it's just to say that it was a lot of work. But ECDC is not just about the projects I've been involved with. It provides you so many training opportunities, and I just summarized here those I've been involved with. The daily roundtable is fascinating because there are experts coming from completely different regions of EU who have an extended experience with infectious diseases and outbreaks, and they discuss about the main threats in Europe, and not just in Europe, because we all know that infectious diseases can move fast. You've heard about the SCIDE, this Congress on Infectious Diseases Epidemiology, and ECDC Summer School is also a good a good opportunity to learn some more about epidemiology and infectious diseases. The evidence-based methods course was also something I've been involved with, and I'm really glad that I attended it because I understood a lot more about systematic reviews and other connected issues. I'm not going to talk about all the meetings, workshops, and conferences I've been involved with because otherwise we would die because we're really hungry and we have to move forward. But I'm just going to summarize something about my traineeship, what it has basically provided me. So a better understanding of my strengths and weaknesses. It has enhanced my organizational and time management skill, forged my critical scientific thinking, strengthened my awareness and understanding of European public health issues, but most of all, it has provided me long-lasting friendships. These are the people I was sharing my office with. These are all the things I was going out with, just to prove you that I was really in Sweden and that I really love Stockholm. Just thank you, grazie, merci, gracias, obrigado. I'm gonna moderate myself, but this is just to invite Rocío for the last part of our meeting. I hope you enjoyed it. Unfortunately, we were supposed to host Santino Severoni, who's a medical doctor who works for WHO in Venice, and he deals with migrant health, basically. He couldn't make it because he's in Rome dealing with all the issues connected to Lampedusa, but he has been so kind to write an official statement that Rocío is gonna read for us. Apart from that, we're gonna have a 3 minutes video that he has sent us, and then we're done. But just wait 2 minutes because there are so many people I want to thank for this opportunity, and then I will give you some logistical information about where to go for lunch, and I think it's really important. So please, Rocío. This one. I will play the video right now. I hope that it's going to be working for you. No? Can we play it from the other computer? Okay, since we have a couple of moments, I just wanted to thank all the people who have made this event possible. All of them know how much they have been involved in this, and I just have to, there are no words to say how grateful I am. But I have just to say that some of you have been really great, and I want to thank, for example, Leonardo here, who has covered both the technical issues and the logistical ones. The other Leonardo sitting there, who has been managing also the Hangout, the teleconference. But I want to thank all of you for your patience and
challenge of health systems is the capacity to adapt to multiculturalism society and to face sudden influx of migrants. This talk is therefore talking on ways to address migrants' health needs and create healthy and flourishing societies. Hundreds and hundreds of migrants die in the Mediterranean Sea and many more in the terrible situation in the rest of Europe. Many of them live in countries with no access to health services. Thousands of women in this very moment are in closed detention centers in Europe waiting for their pending asylum request. While most of these people are escaping from wars, natural disasters, and climate change, and will contribute to the revenue of the receiving countries, the trend in Europe is to treat immigration as a security problem. Migration is and has always been subject to political instrumentalization, not to mention in time of financial crisis. We know, though, that there are important health inequities across sending and hosting countries, and that the migration process often exposes migrants to an accumulation of disadvantages and harmful situations. During the life course of a person, a migration process introduces many variables affecting their health, exposing lack of social and health protection, and this, taking the due security precautions, needs to be addressed as a health issue. In the EU European region, made of 53 member states ranging from Luxembourg to Tajikistan, there is a huge variety of health needs associated with migration. The WHO member states recognized this in 2008 with a World Health Assembly Resolution 61.17. The need to improve migrants' health. In Madrid in 2010, the President continued with a global consultation, and in 2012, member states also recognized the need for reducing health inequalities and ensuring people-centered health with the new strategy Health 2020. All this guidance has been transformed in a concrete project at the WHO Regional Office for Europe, the Public Health Aspects of Migration in Europe project. The goal of the project is to achieve better health for migrants, and WHO is supporting policymakers in using two types of strategies. Action within each country in order to address the specific demographic and political challenges, and action at a transnational level to harmonize policies and preparedness. A successful implementation of measures addressing migrants' health will contribute in creating flourishing countries. The health challenges posed by migration need to be recognized at the macro level context, and policymakers should respond with policies that approach the issue involving the whole government and the whole society. Public health specialists, and particularly those working in the international organizations, as you might do soon, need to provide the evidence and data for evidence-informed policies. In Europe, there is scope to do better on protecting the health of migrants, and you, the new generation of public health specialists, have a great opportunity and responsibility to move this forward. Thank you.
It's just music anyway.
Música es mejor imagen. Yeah.
No, it's just music. It's new music.
Okay.
basically we will share all the PowerPoints that have been presented, and you'll get also the video. Right now I think it's worthy to just go and have lunch. So for the people who are going to be here tomorrow for the EuroNet meeting, maybe we're going to have a break and see the video. But it just lasts 3 minutes. So. And move. Anche ci complimenti come sempre. I'm sure next year we're going to have a presentation about WHO Euro in Venice, because I've heard that someone here is going to do an internship there. So I hope that this kind of meeting, it can be done again, because I believe that it has been really interesting, and I thank you all for being here and for collaborating for it. I think we deserve some food now, so I will wait for you just on the back of the building. Thank you so much.